Thank you so much for coming. We are on the cusp of our third and final day. It's been a miraculous 3 days, and I think today is going to be extremely exciting. I've heard from a number of people that they have looked at the agenda and are very enamored with it and looking forward to it. So this morning we're going to lead off with a very special panel headed by a very special friend and new friends. It is entitled The Benefits of Knowledge Transfer Between KSA and USA, Including Continuous Education and Training of Manpower. The moderator is Dr. Ghassan Abu Alfa. I'd like to just thank him personally because he has been with me for the start almost and has supported it generously, as well as King Faisal Specialist Hospital and Research Center. As you know, they are our main sponsor, and they've been quite generous in terms of support, encouragement, and in going forward as well. So with that, I'd like to turn it over to Dr. Ghassan Abu Alfa, and thank you all for being part of today.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody, and thanks for coming. Can you hear me? We're good? Well, I know it's very early, but I thank all of you for being here because actually you really waited too long for the most exciting panel of the whole program. Maybe I'm biased, but I believe so. I really would like to start by really a very special thanks first for Dr. Qasim Al-Qasabi, the CEO of the King Faisal, because me standing here in front of you is really wouldn't have happened except for the trust of Dr. Al-Qasabi, who just with a phone call explaining what C3 is about, what the vision is, what the mission is, and same time really bringing that opportunity, which we're going to discuss today with the panelists in regard to that exchange of knowledge between the US and the KSA, wouldn't have happened without his support. So thank you very much again for King Faisal and Dr. Qasabi for that. And also I would like to reciprocate by thanking Ransel Potter. Ransel is a great friend. We know each other for a while now. We've been together on the first C3 for healthcare in New York. And I'm really excited to see that C3 is here in Saudi Arabia. This has happened with really a very small idea that started in New York back in April 2014. And really, I have to say, Ransel, I'm super impressed that you're able to put this into action and it's reality like within barely a year. So that's quite impressive. Without any further ado, the intent of the panel is to really show you what are the capacities that I like to use the word celebrate in Saudi Arabia in regard to the possibilities and the innovation that can come up with. But at the same time, we come humbly as collaborators with the idea that it's a two-way exchange, a two-way transfer. It's not really a one-way transfer as sometimes, unfortunately, is misperceived. So I will start with the first panelist, and it's my great honor to introduce Dr. Khalid Musharri, who is the head of the newly established, almost a year now, international office at King Faisal. And Dr. Musharri, as you know, also is probably the founder of a renal transplant program in Saudi Arabia and the Kingdom. And what I would like to ask Khalid is to bring to us where does the international center stand at the moment at King Faisal? What are the missions? And what are the potentials, opportunities that the center sees in regard to future collaboration? And then I'll take you from there with the other panelists. But Khalid, please.
Thank you very much. Bismillah ar-Rahman ar-Rahim. It's really my privilege and distinct honor to present on behalf of King Faisal Hospital Administration the vision and the mission of King Faisal and in that context, what we have in mind for international collaboration. Yeah. So, in terms of volume, just briefly, King Faisal is a reasonably high-size hospital with beds. You all know that we have two components, two sister institutions, Riyadh and Jeddah. This slide summarizes the number of beds in both Riyadh and Jeddah and the number of ICU beds in both institutions. Our vision is really quite clear. We would like to be a world-leading institution of excellence and innovation in healthcare. Our mission provides the highest level of specialized healthcare in an integrated educational and research setting. This is our strategic plan up to 2020, highlighting the 4 or 5 areas of priorities, and we have champions from the administration to lead in each strategic plan. And the last part of the slide summarizes where we are with each of these initiatives. We have really key programs that we focus on in building our reputation as a major healthcare institution in the world. Those are the core competency programs summarized on this slide: oncology, cardiovascular, organ transplant, neurosciences, and medical genetics. These are the highlights of some of the achievements for each of these core competency. Medical genetics is one. Neuroscience is the other. And cardiovascular, in this context, I would like to say that we are one of the largest heart transplant centers in the world. Last year, we did about 26 heart transplant surgeries at King Faisal. And we are listed at the ISHLT as one of the leading transplant centers of the heart. Solid organ transplant in general is no different than heart transplant. We rank probably in the top 5 to 10% of in North Americans' criteria in terms of volume and scope of services for liver, kidney transplantation. We have a growing program in the lung, in the pancreas, as well as in the bones. And these programs have witnessed really tremendous growth in the last few years, as you can see from this slide. To try to enhance our connection with the rest of the regions in the kingdom, we have established a very active telemedicine. I'm showing you just an example of the tele-ICU that we get connected with different ICUs within the kingdom to facilitate care and transfer of patients that are in need for tertiary care. And in terms of accreditation, we are very proud to say that we have received many accreditation international, the highlight of which is shown on this slide, with the JCI accreditation as well as the Magnet accreditation that we have received recently. The JCI is well known to all of you, and the Magnet is for nursing department. That is among many other accreditation that probably my colleagues will address, at least for oncology and bone marrow transplant. As Ghassan mentioned, the international office was established recently as part of the strategic plan of King Faisal to try to foster international collaboration in the areas of exchange of services, transfer of new technology, training, education, and so on. And I'm very proud to say that even before the establishment of this office, we have had many programs that have been implemented, highlighting in this slide some of the programs that we have implemented, collaborating with international centers, predominantly in North America. And we have now ongoing projects that we're working on diligently as we speak, again, emphasizing work with the North American centers to help us move our vision forward and try to achieve all what we have set to actually achieve in our strategic plan. With that, I conclude, and I will be happy to answer any questions. Thank you.
Thank you very much. Thank you. If any pressing questions, I'll be more than happy to take them now. If otherwise, we're going to have a discussion at the end, but please, by all means, if anybody have any questions. Maybe I start with one, just kind of like keep it going. So, Dr. Mshari Khalid, can you please try to translate where do you see most of those collaboration going? In which domain? Is it the academic part, the technological part, research, clinical care? Where do you see the potentials are? And I'd like to see it from the perspective of dual exchange.
I think the emphasis of Dr. Qasabi and the executive management is really, can you hear me? Yeah. Is really to focus on all of these fronts. Definitely, we'd like to stay at the cutting edge in terms of technology, and transfer of new technology is a priority. Education training assumes really a prime importance, and especially what Dr. Qasabi is talking about is really nursing education and training. This seems to be the #1 priority for the administration. Additionally, anything that has to do with exchange programs, clinical collaboration, research, definitely. So I would like to move on the 5 fronts of the international collaboration that I mentioned, but at least for the present time, there seems to be an emphasis on transfer of new technology, as well as education and training, especially for nursing.
That's great. Actually, I would like to say in the morning discussion, as a team, we came very early actually, and we met. And Dr. Mashari, probably consciously or unconsciously, he mentioned one of my favorite words, which is productivity. As you can imagine, in economy, all outcomes of any system, being an economy, a hospital, a home, whatever you call it, it depends on 3 numbers. Potentials, which is employment, numbers in regard to capital, investment, and the last one is productivity. And this is really where I see, because this is, if you look at all economies or all hospitals will all merge together if they have no matter what capital, no matter what employment, because they will all merge ultimately. This is a theory that is well known in economy. But the only differentiation is productivity, and I love very much what you said this morning. So, and this is really where this innovation is going. Dr. Hazzab, please.
Thank you. I just want to echo what Dr. Khalid al-Mashari said on our first day in the workshop on the personalized medicine. We talked a lot about the Genome Project, and even though it is through the CAXT center, but the King Faisal Specialist Hospital is actually the leading partner with that, and I know we have come to a lot of collaboration in that workshop, and I'm hoping that there will be further collaboration between the King Faisal Specialist Hospital and through this forum for the personalized medicine, because as we know now, the Genome Project is actually one of the leading it's going to be one of the leading healthcare projects that will actually change the medicine through personalized medicine. Thank you.
Very nicely said, thank you. Great, without any further ado, I would like to introduce the second speaker on the panel. It really very perplexing when I introduce really a very, very dear friend and somebody who is well loved over here, Dr. Hassan Salah. So Dr. Hassan Salah, in his capacity as Deputy for Clinical and Medical Affairs at King Faisal, with a really very rich background, started in Seattle. This at least where I followed. and then with really key presence at the UB, and now here in King Faisal, with really a key interest in regard to how to involve or nourish as a administration this kind of collaboration. And obviously, Hassan, I would ask you please also to put a little bit of perspective from our experience at the UB as well.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, good morning. It's really my pleasure to share this session with my colleagues. I have a few minutes to touch on an area that Dr. Mchari already mentioned as one of the core competency areas at King Faisal Specialist Hospital Research Center and other centers, as you all know, in the kingdom and the region and worldwide as well. Before I start, I would like to thank the organizing committee. I would like to thank Ransel and Ghassan for their efforts and their vision about establishing collaboration in our region between the different institutions. Dr. Mshari addressed in his presentation the strategic plan for King Faisal Specialist Hospital. And if you look at the core competency areas, it's probably in some aspects similar to other major institutions in North America and the region. One of these areas, as you know, is oncology. And cancer, as you all know, is really a major burden to healthcare. Because of time limitation, I'm going just to highlight some of the points relevant to the problem of cancer and what we are doing at King Faisal Specialist Hospital with respect to addressing the problem of cancer in the kingdom and also in the region, because this is part of our mission as far as education, research, and patient care. And also address what is the potential for collaboration between major institutions within the kingdom and North America, specifically with Memorial Sloan Kettering Cancer Center and the American University of Beirut. So you all know that cancer is the second common killer in the world after cardiovascular diseases. And by WHO statistics, 13% of all death is due to cancer. It's a global burden, and the shift is now from affluent countries to less affluent countries. And with the new changes in lifestyles and the increase in the population and the aging population, particularly in the region, we're going to expect significant increase in the number of cancer in the kingdom, cancer patients in the kingdom, and in the developing countries in the region. Just a few points about the statistics, and then you can imagine what's the burden that we're going to face with respect to cancer as a healthcare problem. And these are statistics by WHO. In 2030, you would expect there will be 17 million patients dying from cancer worldwide, and at least 1 million in the East Mediterranean region every year. And the statistics show that there will be 75 million patients having cancer at any time being treated, and in the East Mediterranean region, about 4 million. The increase in death in established economies, it will be the increase over the next 15 years would be 20%, while in developing countries, the increase in death over the next 15 years will be by 180%. So there's significant increase in percentage of death. Now, out of these patients, as far as figures, 60% of cancer patients are diagnosed in developing countries. In the kingdom, the number of patients, and this is based on the Kingdom Cancer Registry, in 2011, we have 16,000 patients in new cases every year. Projection for the year 2030, in 15 years, we're looking at 50,000 new cases diagnosed every year. And keeping in mind the cost of healthcare, increasing cost, and keeping in mind the long duration of therapy, then one would imagine the burden on the economy in the kingdom as well as in developing countries. So in 2012, 20 billion US dollars were spent on healthcare in the kingdom. So one can imagine if we're looking at increase in the health care cost, what would be the burden on the economy. So based on the vision and the mission of King Faisal Specialty Hospital as addressed earlier by Dr. Mshari, and this is the strategic plan for 2013 to 2020, we have demand for the service. I'm talking about cancer patients. We have advances in biotechnology, and we have increase in the cost of healthcare. The strategic plan, one of the pillars of the strategic plan address establishing world-leading services, specifically in the core competency areas, as Dr. Mshari mentioned, including cancer, and also collaboration with other centers in all the areas, patient care, education, and research. Now, if you look at our institution, as King Faisal Specialty Hospital, we have the infrastructure for clinical services, we have infrastructure for research, we have the expertise, we have the technology, and we have all the requirements for IRB systems for research. And if you look at the potential for collaboration with other institutions, namely Memorial Sloan Kettering Cancer Center, their expertise in the area is well known, and I think we should have mutual plans together about collaboration in the area. American University of Beirut, and I'm very familiar with their system, and unfortunately Dr. Fadi Bitar could not join us today to talk about the potential collaboration. They have also infrastructure for research and for clinical services, and they have close collaboration between Memorial Sloan Kettering Cancer Center and AUV, where they have established, as far as patient care, they have tumor boards, they have consultations, they have exchange of staff at all levels, be it residents, fellows, junior staff, as well as senior staff, and they also have worked together to establish a tissue bank with common database to use for research. The point that Dr. Salwa Al-Hazza addressed is extremely important because, if we look at the strategic priorities for our institution at King Faisal Hospital is to increase capacity and through research provide better patient care. And personalized medicine, specifically in cancer, is one of the most important areas that at present we are tackling with respect to clinical services and the research center at King Faisal Specialty Hospital, not only in cancer, in other areas, but because our priority is cancer, I think the focus is timely. At the present time, we are looking forward to increase the capacity of our institution with the commissioning of King Abdullah Center for Oncology and Liver Diseases. This will be a landmark in the region, not only as far as capacity, 300 beds that has state-of-the-art technology with smart patient rooms, with all requirements with respect to equipment. We have a brain suite, we have radiation therapy equipment, state-of-the-art, as well as advanced clinical informatics, which will enable the institution to provide not only the best patient care, but also take it further to improve research in the institution. So our focus as far as research and patient care, in addition to education, would be, as I mentioned earlier, personalized medicine, as well as specific areas that we included in our strategic plan, which is stem cell therapy. And as you all know, it is a very important area that many centers are advancing their programs with respect to not only putting in resources, but also focusing on research to develop programs in stem cell therapy. Not only for cancer patients, but also for other types of diseases. And at King Faisal Hospital, we are well known worldwide for our programs in stem cell transplantation. So I know that there will be many questions to address the point that I presented, but I would like to request Dr. Amal Suraihi, who is the head of section of pediatric stem cell transplantation at King Faisal Specialist Hospital, to address the role of our institution in stem cell therapy. Dr. Suraihi has vast experience in stem cell transplantation, and her role in this field, specifically with respect to quality of stem cell transplantation and accreditation. Maybe some of you don't know that our institution is the only institution in the region at the present time to have JC accreditation for stem cell transplantation. Outside Europe and North America, we're the only institution that have accreditation, and Dr. Suraihi had a major role to get this accreditation. Dr. Suraihi.
Assalamu alaikum and good morning, everybody. And it's a pleasure to be here to present our humble experience in stem cell transplant as one modality of treatment of cancer and other disorder as well. I'd like first to highlight where we are as one among the Eastern Mediterranean area. This is the survey was carried for the number of transplants performed between 1994, since the establishment of stem cell transplant in the area, till 2010. And as you see, King Faisal is among of the highest performer transplant. Iran, Egypt, as well as one of the largest transplant program in the area. But if you take in account the number of populations of Saudi Arabia in comparison to Iran and Egypt, this is a great achievement in 20 years. So we perform about 3,000 transplants as of 2010, but the latest statistic is more than 5,000 transplant, adult and pediatric. This is a brief of the development of the stem cell transplants program at King Faisal Hospital, which started in 1984 as allogenic transplant. A year later, we started autologous. In 1993, pediatric transplant became separate from the adult. In 1996, we started immune therapy, donor lymphocyte infusions. 2003, we expand the source of stem cell transplant or alternative donor source. First transplant was performed in 2003. In 2005, we first unrelated donor from USA. 2008, we have our Saudi cord blood bank at King Faisal Hospital, and since then is the main source of cord blood. I think by 2013, almost 99% of the cord blood transplant was performed from our bank. Our collaboration was with the New York Cord Blood Bank, was the main source of our cord blood unit before we established our Saudi bank. 2013, we explored the area of haploidentical transplant, and so far we perform, I think, more than 15 cases between adult and pediatric. Accreditation and membership. I think one of the very strong point that we have for our program is the BMT database, which was established very early on the transplant on the 1993. So we report our data to CIBMTR, the Center of International Blood and Marrow, and also to the European Group of Blood and Marrow since 1993, and now we are sharing publication and study. We become accredited for National Marrow Donor Program since 2004. King Faisal Hospital take the initiation of establishment of EMBMT, Eastern Mediterranean Bone Marrow Transplant Organization, 2008. Regarding the quality, we work since 2008 to 2010 to implement a quality assurance system that cover all the area of the transplant, which is the clinical collections and processing, and we become accredited in 2010. This way we are applying the international standards of clearance, patient, recipient, donor, and stem cell transplant product. JC is equal to FACT in North America. This is the number of transplants that had been performed since 1984, and as you see, it's steadily increased over the year. I think the more number was performed after opening the area of alternative donor between 2010 and 2014. The average number for the last 5 years around 300 transplant. This is show the allogenic transplant. Pediatric transplant perform more allogenic than adult. The main indication for pediatric allogenic transplant is in our area is inherited disorder, which include immune deficiency, thalassemia, sickle cell anemia, bone marrow failure, and that's different from the other part of the world where malignancy is the main indication for transplant. For adult is the actually leukemia followed by myeloproliferative disorder and thalassemia, bone marrow failure, and again that's a little bit different from US and Europe. Autologous transplant, the main indication actually in the adult program is multiple myeloma and lymphoma. For pediatrics, very limited indication, neuroblastoma and Wills tumor. We have been recognized by CIBMTR as one of the highest reporter program. As of 2011, 13, sorry, we received the appreciation from CIBMTR. According to their analysis, we are among the largest 5% center reporting to CIBMTR. I would like to highlight on the one of the regional and international collaboration as well. King Faisal Hospital in 2007 take the initiative to put the countries in the Middle East together, those who has a transplant program. It was established in 2008 as a cooperative platform for physicians, scientists, and healthcare workers from institutions in Middle and Eastern Mediterranean area with the goal of sharing experience, initiation, cooperative trials, and establish common strategy to achieve optimization in the field of hematopoietic stem cell transplant. The aim is to promote all aspects of patient care, academic research activity related to stem cell transplant. I think one of the major achievements having our own journal since 2007. Dr. Al-Jurf, the director of adult stem cell transplant program, is the chief editor. It's called Hematology Oncology Stem Cell Therapy Journal. And this is some of the publications that actually reflect the cooperation in between these centers. Thank you very much.
Thank you, Dr. Sarahi. Thank you, Amal. As you can see, we pretty much presented quite a bit of substance here, and I'm sure it's not foreign to many of you. Any questions, by the way, for Dr. Sarahi in regard to the transplant program that King Faisal has? Question in the back? It's a phone call. And any question for Dr. Sulh as well? Okay. All right. What I would like to do is actually I'm going to carry on, and then we will pause at the end for some further interaction. But what my job is going to be is try to kind of put all of this together in regard to what already has been going on. I have a little bit of difficult mission this morning because unfortunately Dr. Fadi Bitar, who is the head of international affairs at the American University of Beirut, could not join us. So I will take on my part representing my alma mater, the American University of Beirut, where I trained as a medical doctor. And then I will carry on with my experience as being on the faculty at Sloan Kettering now for almost 15 years, during which we brought up a quite innovative program in regard to international collaboration that really was the ante to a business establishment approach that really probably will celebrate most human capacity. We noticed that probably the best way to evolve in a relationship is to start from bottom up. So we kind of buddied with the American University of Beirut, and this happened pretty much at the exact time, and probably this was like ripe in time, when Muhammad Sayegh, Dr. Sayegh, came as the dean of the medical school as well as the vice president for the medical affairs at the American University of Beirut, coming from Harvard. And he brought with him a vision for 2020, or what's called Vision 2020, which carries 5 pillars in regard to what AUB will achieve as a key player in the region, same as King Faisal would. And one of those pillars was about international collaboration. And when we brought the model to AUB, it was very welcome, and really it's built on no more than a handshake, but a lot of donor money. And we kind of initiated a formula where the donors, who are mainly Lebanese American, is to deposit the money in memorial and to evolve in through an endowment in regard to building those activities that we did together. Just kind of like, go over the activities very briefly and tell you where they would go from there. We have actually exchange faculty program. where the faculty are very welcome at any time through the 2 different campuses, and whenever there is a need for any of the faculty to come for either learning a new procedure or learning about a new disease, we're very keen on understanding how cancer evolved in the Middle East, so a lot of our faculty come to AUB same way. This is a program that has been nourished for the last 9 years or 10 years now. In addition to that, we exchange our knowledge base on a regular basis through video links, and we proudly have a video link in gastrointestinal malignancies that has been running uninterrupted for the last 9 years, where every month we'll get on the conferencing through video link, and it could be either from AUB or from Memorial. And I would like to acknowledge here that also we've been doing this for the last 6 or 7 years with Dr. Jazi from the National Guard here in Riyadh. And we pretty much will present the case, bring the expert, and what we'll do is try to kind of build some value and learning potential from that case. We pushed it a little bit further. What we do actually, all of them are taped. They are available on demand. They are kind of educational material for the fellows. And most importantly also, we are committed to publish those interactions, and we have proudly already about 30 publications in regard to that interaction just shared between the 2 institutions or 3 institutions. The program was quite successful that we reciprocated it in breast cancer. It's a little bit of a different formulation, and I see what I'm trying to here imply also that we're very flexible. We let people decide what's best for them. So the group at AUB under the care of Dr. Naji Saghir, who is the head of the breast program, will actually prepare the cases, and Cliff Huddis, who is the president of the American Society of Clinical Oncology until last year, will designate faculty to try to interact with the AUB faculty and fellows to try to kind of learn from the cases that they are building up in the educational setting. And this again has been going on for almost 4 years now. We're already building one in thoracic, we're following it on in GU, so kind of like, as you can imagine, we're going from one to the other. In addition to that, we have a very particular fellowship program where the cream of the cream, if we see high potential in any of the trainees at the American University of Beirut, we take them under our wing and we offer them fully paid fellowships in research in a domain that they are interested in. And with the intent that after they complete that kind of program, they will go into very highly competitive domains as well as very highly competitive programs in regard to their training, with the understanding that ultimately they will be serving the institution back at home. And we have to say proudly that we completed only this program once. We are not necessarily committed to do it every year. We have a graduate, her name is Carla Haj, and she spent 2 years in radiation oncology at Memorial, and probably she is the first international residency candidate in radiation oncology at Memorial. And I have to announce, as of last week, Carla was appointed as the chief resident in radiation oncology at Sloan Kettering. As you can imagine, this is a very solid achievement, which really bring in the capacity and introduce Memorial to it, but at the same time, we introduce our capacity and vice versa. Add to this, the tissue bank that Dr. Sulh just brought up has been really the brainchild of Craig Thompson, the president and CEO of the Memorial Sloan Kettering. And the idea is, as you can imagine, King Faisal is actually super advanced in regard to tissue banking. This is not the point per se, and AUB will do the same, it's a matter of database. It's a matter of either having a small database based on a small country like Lebanon, or a bigger database like Saudi Arabia, or a huge database like, that will join those kind of institutions together. And we proudly, through a lot of work, and I can't tell you how many people were involved, we had to study the Lebanese law in regard to genetic modulation. What can we do? What can we test? We had to put protocols together. We have a joint protocol that actually is shared between the American University of Beirut and Sloan Kettering, where AUB is now the only institution in the world that have direct access to the database at Memorial, where they just enter it through a website and will be entered the information. I made sure that when we build this, it's a reciprocated program, and this is something you're going to hear from me as well, is that we really believe strongly in reciprocation, i.e. a researcher at Sloan Kettering, if they are interested in any of the material that's available at AUB, is definitely available to them. There is an MTA in place, and they can just fly it and do whatever testing. But by the same means, if a AUB researcher is interested in material from Memorial, huge database, they have the same access. And this is really, again, what we pride ourselves in, that kind of, interaction that we do together. One of the programs that we pride ourselves as well in is actually a training course, but I have to say probably it's more training courses, like really where we build friendships, that's on competitive basis offered between the American University of Beirut as well as Sloan Kettering, where we invite any specialty in a relationship to the domain of oncology, being medical oncologists, radiation oncologists, surgeons, to apply for a proposal of a certain either research they would like to do or some clinical findings they'd like to present. And usually we spread out our reach from North Africa to the Middle East and sometimes also Southern Mediterranean. And we pick out of the applicants, and be assured we got a lot of applicants among like a database of 3,000 of those interested people. We pick up literally 20. And these 20 are actually fully paid, flown to Beirut in 2013, where in the morning they will have didactic work for only a few hours, but they spend the afternoon working on their research and try to see how can they convince each other that their proposal is the best of all. We bring a very specialized team in leadership development, and this is where we see really a very big thirst and need, and we let them twist within that kind of exercise to really try to learn how to compete, how to listen, how to learn, how to interact. And then midway, we confuse people and we tell them now time's to cooperate. And we ask them to pick among each group one specific project that they feel this is the one that should win, but they have to have all of them commitment to that project and they have to support it. We ended up with 2 groups at AUB back in 2013, and we proudly can say that both of those groups were able to publish their material already. It's quite impressive within a very short period of time. And also we give what's called the Seed of Leadership Award. And I have to say, one thing that I pride the program in, that all receivers are women in the Middle East, and one of them actually is from the National Guard, Dr. Nafisa Hafiz, who received it back in 2013. The experience was very successful enough that actually the Hamad Medical Center in Doha, Qatar, bought on it with the work of our very dear friend who is a memorial graduate, Dr. Alexander Knuth. So last October 2014, we were in Doha with AUB, Memorial, and Hamad, as well as with Cornell, Qatar. And we did the same thing, but we upped the dose a little bit. This time, instead of doing only clinical research, we asked for basic research that can be done among those institutions. We have 2 projects already. One of them is under review by the Qatar Foundation, and another one is under review as well. And we hope definitely to have those published. No doubt that this program is to carry on. We're really zeroed in on doing the program with King Faisal, but not only necessarily start chopping around, but rather have a long-term commitment. We feel that, and we are strong belief that King Faisal will be a key player in regard to a program of that kind in its presence here in the kingdom as well as in the region. And as you can imagine, the program aim is to try to build the human capacity. It's trying to build an opportunity for our young junior faculty as well as senior fellows, an opportunity to kind of like, know the leadership abilities that they have in their hands. And as such, we kind of like, as you can tell, we are seeding all over the place ambassadors that we pride ourselves. We have 20 from the first program, 25 from the second one. These are 45 ambassadors for Sloan Kettering at AUB interaction all over the Middle East, spreading from Morocco all the way to Iraq and in between, that are there to help in regard to clinical care, are there for innovation, and they definitely get enlightened and encouraged with all what's going around them in regard to really the belief that we put in themselves and we make them really be assured about. Where do you go from there? As you can imagine, this is not a one-person work. This is a lot of people being at now our joint friend, King Faisal, with the direction of Dr. Qasabi. At AUB now with the new president, Dr. Fadl Khouri, who has just joined AUB, which is a great excitement for the institution. And already within literally 24 hours from the appointment of Dr. Khouri as the president for the American University of Beirut, we had an interaction, including the team from Sloan Kettering, in regard to pushing forward in that relationship. under the direction of Craig Thompson and Mary Brennan from the Sloan Kettering Group. Definitely there's a strong commitment in regard to that relationship. And we have also members of the boards that really are strongly believing, and ultimately we will have that presence here, but we're building it in a different way. We're building from bottom up rather than from top to bottom. And I would like to mention here, actually, our very good friend, member of the Board of Trustees of the Sloan Kettering, as well as of AUB, who truly was the introduction to the C3 to begin with, which is Mrs. Hutham Al-Olayan, who really strongly believe in that potential that we can build together in that regard. Where this will take us, we don't necessarily have anything in writing, but except for, of course, the project we do. We have the vision, but we let things evolve themselves. But as you can see, we already are in action. We're not here to give directives. We are really already in action, and we execute very, very efficiently in that regard. So I'm going to stop here. I think we kind of we put together why now you can see this kind of very fine panel was put together, and I will open it for questions. Thank you very much.
Thank you. It's just because nobody else asked questions, I looked around. So
No, don't worry. We'll encourage them.
I'll just go ahead. It's actually two questions. One is for Dr. Ahmed. Thank you for the excellent presentation. You showed the nice slide with the statistics of the transplants. You mentioned King Faisal Specialist Hospital, but the slide actually showed Kingdom of Saudi Arabia. So did that include all the transplants in the kingdom, or was that just limited to the King Faisal Specialist Hospital?
Only reflect King Faisal number, only King Faisal number. But we have, of course, there are several transplant programs in Saudi Arabia. One of the active transplant here in Riyadh is National Guard, and I think if according to, I presented this data in 2013, according to my personal communication with them, they perform about 50 transplants per year. There is another small program in Dammam. It's about 20 to 15 cases per year. In Jeddah, King Faisal hospitals, about 30 to 40 cases per year. So this is like late 2012.
So the graph in reality is KFSH and not
Exactly.
KSA.
Pure King Faisal.
The second question is to Dr. Saleh. When do you think the patient will be able to walk into your clinic as a cancer patient and have his whole genetic code on a smart card, where you'll know exactly which anti-cancer medication you'll give without having this trial and error or the side effects? Do you think this is going to be soon? Will King Faisal be actually the pioneer for this?
This is a very important and timely question. The reason is, as I mentioned, personalized medicine is at the top priority in our institution at King Faisal, not only from the research aspect, from the clinical services aspect. And at the present time, we are working closely with the research center and also with the Department of Pathology Laboratory Medicine, looking at genomic studies that we are doing at the present time in collaboration with certain institutions in the States, where we are doing the test with validation with respect to quality control. And I think, hopefully, I don't have a specific timeline, but within a few months, we would be able to have a profile for the patient with respect to genomics, and we will be able. This is not only will improve the outcome, but also will save on the cost, because as you know, we do too many studies. Sometimes we get into protocols that may not be properly indicated because of lack of understanding of the biology of the tumor and also the profile of the patient genomic profile, which will help in tailoring the proper treatment. So it is within a few months, but I'm not sure what would be the exact time. Particularly for certain diseases, we're going to do it. We're not going to be able to do it across the board, but for example, for breast cancer, we're making significant progress, and maybe breast cancer would be the first disease that we will be able to look at providing customized therapy based on genomic profiles.
Yeah, if I might here, actually, this is well timed. So the tissue bank project that we have with AUB is going to be amended this summer and will include actually impact. Impact is our actually genetic coding at Memorial, which is developed by the capacity of everybody at Memorial. It was literally like a town hall meeting where everybody at Memorial could put in their efforts and the reason why a certain specific gene should be on that panel, which currently has in version 2.0, which is about 430 genes, one of the largest, but with the strong presence of clinical data, which sometimes some of those private companies like Foundation One and KSA, they do a beautiful job, but it lacks the clinical data because of HIPAA requirements. So this actually is going to be embedded in tissue project that we have with AUB, and we'll be able to do this across the board. So I can definitely see here a potential also that this will be built up. Even though I have to say, I will put a word in caution on all of that, and I'll say it in Arabic, اقرأ تفرح جرب تحزن. And I think it applies only for breast cancer and colorectal. There's high applicability, no question about it. Actually, it's Medicare covered, and you can do it without any problem. But it comes to other diseases, I'll tell you, it's like a endless, infinite number of variation of those diseases. I'm not really sure by only defining them we're going to get there. I'll be actually next week be giving a lecture about the practicality about genetic impacting at AUB, part of the Middle East Medical Assembly, and we have a beautiful model, if any of you will be there, about like how we perceive it differently, which ironically is based on how the Pandora music is built in as a program for Pandora. So if you are there, you will enjoy hearing that. So please, I think there's a question.
Thank you, Dr. Thank you, Dr. Qazan. Thank you, Dr. Khalid. Thank you, Dr. Hassan. Thank you, Dr. Aman. My name is Badr Hablani. I'm from the research center at the King Faisal Specialist Hospital. In terms of registries, you mentioned that we have the largest cancer registry in the region. What about other registries? Do we have a good future for these disease registries?
Who would like to answer that?
I can tell you about the solid organ transplant registry. There's a project in collaboration with CAXT to establish a registry for solid organ transplant. It's already approved, and we are accruing data as we speak. I think your question is right on target. We have to have registries for all of these entities, especially for the core competency program, because you have to have database. You have to. You can only build on what data you have. And in fact, the collaboration that Hassan mentioned, as far as the tissue bank with the memorial, is one, but is a good example of how can we build on data. But we have to have our own registry to start with. And beside the registry that Hassan mentioned, there's a registry that has already been launched for solid organ transplant. I would like as well to really ask other core competency programs to establish their own registry as well.
Great. I have a second question. In terms of clinical trials, do we have good infrastructure to start having more clinical trials regarding, for example, cancer?
I can't probably answer on what's the abilities, even though what I know, at least through my interaction, yes, it is. If anything, my job is by starting with tissue bank, which we consider what's called a low-risk project, a low-risk program, because it's a clinical trial by definition, is really if we are able to do all due diligence and find that things are executed in the same capacity, I absolutely, by all means, this is really where I would like to go. I strongly believe that everything is already in place. The IRB at King Faisal is already present, which is a key core to the element of that. If anything, what we would like to do is enhance a little bit of cultural exchange in regard to the interaction. And I probably can reflect a little bit on the interaction with AUB and between the IRBs. What we did actually, we flew the whole IRB team from Memorial back to AUB, and we did the same vice versa. Because we felt like, those teams need to know each other and they need to interact quite a bit. And we noticed that IRBs in general have a little bit of a, uncomfortable, to say a gentle word, taste in institutions. And Memorial has succeeded in building an IRB which is more rather supportive rather than being policing, while of course still applying what's necessary. And we have learned and we have seen live how this kind of like translation of culture has evolved quite a bit. And now we're helping AUB in building their first research assistant program for training that all our research assistants will do at Memorial. We had the first of them coming to Memorial, spend about 2 weeks on a intense program, and now we're trying to build it as an on-demand video ability. But I think once you put those pieces, and they are very easy to execute, I think the will is there, the infrastructure is there, it's a matter of just time, we'll see it happening. Thanks for bringing it up. Any other thoughts, questions?
Hi, hello.
I
have a questions for you. Actually, one of the challenging issue that we have and we're going to face soon is with increased indication to transplant and expanding the source of stem cell is the availability of qualified staff. So one of the area that we are working on is to establish a fellowship in stem cell transplant. We are working the adult and pediatric. I think we have all the materials to develop this program, but I think it would be a great opportunity for our candidate to also get some training abroad, especially in USA and in like a prestigious center. I know there is a limitation in regard, but we have been approached by several centers that they can facilitate this. One area also nursing coordinators and research, but I would like to focus on the training. How do you think this would be possible and requirement, especially with the issue of the SMLE and licenses and all these things?
A very good point. This is one of the challenges which unfortunately is not guided by the institutions, but rather by the governance of the American boards. What we've done with AUB, and I think Hassan was a very critical player in this one in his days at AUB, is the fellows do come. I have to admit there is a limitation to the experience because it's observership. But what we learned is we kind of like try to marry it between a little bit of time in clinical work and a little bit of time on research. And as such, they have a little bit of more hands-on experience because they're involved in their own project. This is probably like how to say the poor man's choice for something limited by the USMLE abilities. And the question is, even if people have USMLE and they are totally certified, unfortunately, because they don't have license in the state they're going to practice in, and these vary, of course, among states. At least I can talk about state of New York. That's why there is a limitation of practice. Ironically, if you bring a medical student from before their medical degree, they have more access, more abilities than a residence in training. But on the other hand, in regard to the other abilities, yes, we're doing it already. AUB actually give us a list, like we need pharmacy training, we need radiation oncology, we need a physicist, etc. We just kind of match people. Some of them, we already have programs established at Memorial, so this is much easier. We just, tuck in people and they get into the program. And others, we actually are quite innovative. We build the program together. But obviously, that kind of very normalcy of relationship. And when I say that, it's like, you walk into the halls of Memorial and say AUB, people will 11 years ago it was UAB, University of Alabama, Birmingham, but now they are AUB, they know who they are. And that's really very important. This is really where we are, is that like you say AUB, oh yeah, no problem, I know Dr. Salah or I know Dr. Sayegh, I'll do that for you. And that's really the normalcy we're trying to build up, but definitely there's potential. Yeah.
If you allow me, Ghassan, maybe Dr. Mshari will comment on the accreditation for the renal transplant fellowship at King Faisal, which is really important for.
I think I was going to suggest that, and speaking of innovation, Ghassan, you might want to look into that. What we have developed, as I mentioned to you in the brief meeting before we started, that we, in collaboration with the American Society of Transplantation, and specifically with the help of Mohammed Sayegh, we were the first transplant center outside North America to get accreditation for fellowship training in transplantation. They have certain very rigid criteria that we fulfilled, and it required a site visit where they looked at our activity and curriculum of training. So one thing that probably you can approach from your end is to explore the potential of having like some kind of hybrid program where fellows can spend some time here in a accredited program. All of the requirements for admission to the US will have to be fulfilled. And then part of their training can be done outside so that we can get around the business of having no enough slots or all of the regulatory issues that will come into play. And I think we found it very successful. We already, from this program, we graduated about 4 fellows since it was started in 2008. And it was really a very successful endeavor of absolute collaboration, especially for training. So we have, for example, the bone marrow stem cell transplant programs. What's wrong of exploring accrediting the place here for fellowship training with some caveats of collaboration with, for example, key centers in the US, the idea of which is for the fellow to finish his training after he fulfilled the requirement for admission to the US, and eventually, if it's required, he will spend more time in the US to get whatever is needed to get the full certification.
Fair enough. Congratulations on your program, which was so nice to hear. But at the same time, definitely, the sky is the limit. I mean, there's potential. I think once we have the capacity and we are talking to each other and there's interaction and the trusted build-up, and it's not an issue at all. Everything can be discussed and negotiated. There are certain governing laws we just have to circumvent or we have to adapt to. But at the same time, I think the more we bring to the table, the more we can actually bring that innovation onto play. Great. One last question. We'll take one last question, please. Yeah.
Thank you so much for the discussion. I wanted to pick up on something Dr. Amos said, which is the need for training of other than physicians. And I wondered if each of the doctors could comment on what they see as the top priority for the ancillary staff. That includes nursing, basically non-physician, where there's a gap in knowledge, whether it be management of healthcare institutions, whether it be a clinical issue or whether it be the financing of healthcare. Where are y'all seeing gaps where American institutions or educational programs that are specialized in that area might come to Saudi? Because I think there's a great deal of emphasis on sending Saudis to North America, but there's an awful lot of skills and knowledge that can be brought in shorter training courses and conducted in Saudi, and then more Saudis can come and attend, or even Mina could come and attend a session that was to be held here and do a knowledge transfer that way. So I'm just interested in what y'all think might be the top priorities for something like that.
Excellent point. Thanks for bringing it up. Maybe Hassan, we'll start with you.
Yeah, I think this is a very important question. We're addressing, physician training, be it residents, fellows, but at the same time, the nursing staff, technical staff, and paramedical are very important part of the team. Now, I think one of the areas that we need to focus on, and Dr. Saraihi mentioned, with respect to nursing, the role of the nurse practitioner is not very clear in our institutions. And we need to develop this role and make sure that we have the nurse practitioners take in the role of quote unquote registrars or assistant physicians, because they do a great job by linking the patient needs and the physician, and try to put help the medical team to put a plan for the management of the patient. So I think we need to have training in nurse practitioners in subspecialties, because we are talking about tertiary care, we are talking about core competency areas, be it on cancer, be it cardiovascular, neurosciences, and so on. So we need to have this role defined. Also, there are certain areas that we need to focus on, and recently we have made progress with respect to technical staff in radiation therapy, and also in certain areas in the lab, technical staff with respect to cytogenetic studies, molecular studies, but we made progress recently in this area. But I think the focus should be, as far as nursing, is the role of nurse practitioner and coordinators. The point that was addressed earlier with respect to the clinical research coordinator nurse, clinical research nurse coordinators, because if you have clinical trials, you need to have experienced clinical research nursing coordinators. And I think this is critical, so that they have the proper knowledge, not only for the phase 3 trials. I'm talking about the phase 1, phase 2, which I think more and more If we're talking about research-driven patient care, we need a phase 1, phase 2 clinical trials.
Absolutely, and point well taken. And I have to say that we tried an attempt on that, and we should follow on it. There was a program joint between Memorial and the AUB for the Lebanese Society of Medical Oncology, and we had a nursing program in it. And the idea was to kind of like start enhancing that relationship. I think, you know, there's so much ability. I can't tell you, like, you know, how innovative we've been. And the nice thing is that, like, really it's like an open forum. We just, like, whoever want to come on board and they have an idea, we say absolutely, you know, by all means. But I think that's definitely a point well noted. So I probably will end up here, but I thank you all for coming that early and for your attention. We'll be around if anybody has any questions, but I would like again to thank truly Dr. Al-Qasabi for giving us that opportunity as the head of the King Faisal, and thanks again for welcoming into the Kingdom of Saudi Arabia. Thank you very much for the panelists. And I think Ransel would like to.
So thank you very much for that, panel. You were wonderful, and now we'd like to give you some awards for your wonderful presentation and participation. So we're going to start with, obviously, Dr. Ghassan, please. Next, we'd like to give the award to Dr. El-Sol, please. Next, we'd like to give an award to, and I hope that I pronounce this correctly, Dr. Khaled. Yes. Thank you. And then, of course, Dr. Amal, we'd like to thank you. You were very wonderful, and please come forward.
Yeah, absolutely.
So thank you very much. That concludes our first session of the morning. We are now going to ask the next session, which is going to be moderated by Dr. Nahar Al-Azimi, who is Deputy Assistant for Hospital Affairs for the Minister of Health. And the topic is how to improve patient safety, a basic tenet of medical practice, which is something that we're all very, very dedicated to. So please, will the next panel come up? And thank you very much, panelists, for being part. We're going to do a group picture before they leave.
Session on how to improve patient safety. I'm sure that it will be an interesting, informative discussion, since we have a great speakers and panelists participating in this session. And I'm very honored and pleased to be the moderator of this session. I'll be starting introducing our panelists, and we will, as agreed, will give the colleagues the time to just talk about the theme and cover the theme from a different aspects. In fact, as you know, patient safety is a very important aspect of our practice and a big concern for policymakers, administrators, and practitioners. So this is why it's, a basic tenet for medical practice, as said in the theme. And I'm very honored to introduce our speakers today. And I'll start with Dr. Philip Anderson, who was the assistant professor at Harvard Medical School, program director at Brigham and Women's Hospital, the program director on International Emergency Department Leadership Institute, and he's a consultant emergency physician. Another emergency consultant physician, Dr. Ahmed Al-Amri, who is the Executive Director and Quality and Patient Safety in the National Guard Health Affairs from Saudi Arabia, and he is, as I said, a consultant emergency physician. I'm also pleased to introduce Dr. Khalid Al-Gumezi, the Assistant Professor and Consultant of Family Medicine at Al-Imam Muhammad bin Saud Islamic University, and Mr. Emilio Williams Lopez, the Director of International Programs, University of Chicago Medical Center. Talking about safety, I'm sure we will cover a very important, aspects today. One of them is the safety culture, which is an important, concern to build in the healthcare institutions. Not only in our developing world or countries, I think, as I was discussing with Dr. Philip, it's also in the developed healthcare systems, we still have this punitive culture or looking for whom to blame. We will also, through the themes, to cover the role of technology in improving the patient safety, and will reflect also, our speakers will reflect on our experience in Saudi Arabia in building models for patient safety. I will start with Dr. Patrick and probably ask him to start his speech and theme, and as he is interested in some techniques of surgical checklist and the CPEO, where the computerized order entry, I'm sure we will enjoy this speech. So Dr. Patrick, please.
Well, thank you very much, Dr. Nahar, and thank you to the organizers of the meeting as well, Ransel and others. It's a real honor and a pleasure to be here together with all of you here at the beautiful venue that we have here in Riyadh. I just want to echo some of the comments that Dr. Nahar made about the scope of and the concern that I think we all share regarding patient safety. Reducing preventable adverse events that cause harm to patients is a concern that we all share. The WHO has noted that as many as 1 in 10 patients receiving care are at risk for having preventable adverse events. And the data that is based on, it comes in part from a study that was done at the Harvard School of Public Health called the Harvard Medical Practice Study. And that study found that in patients who are hospitalized, in the United States, there are as many as 44,000 to almost 100,000 preventable deaths that occur every year as a result of medical errors that happen in hospitalized patients. And when you look more closely at that information, what we find is that the most common cause of those medical errors are involving drug complications, medication errors. The most common site of those happening, the most common site of care, is actually in the operating rooms with patients that are undergoing surgical procedures. Now, in the emergency department where I practice, it was found in this study that about 3% of medical errors happen in the emergency department. But very concerning is that as much as 70% of those are felt to be due to negligent care, which is higher than any other part of or site of care in the hospital. And so this data, happened and was based on care that was provided back in the 80s, and since that time, the role of emergency departments and the specialty of emergency medicine has evolved considerably to a point where now, in the more modern paradigm, the emergency departments have become the the main portal of entry to hospitals for patients with acute problems. And the scope of care that's provided in emergency departments has become more specifically defined, allowing for us to develop more specific training programs. And I think also during this period, we've also had more of a continuous focus on process improvements, and these have all, I think, contributed to the improvements in care that we're now seeing, and the improvements in patient safety that we're seeing in emergency departments. And some of the benefits that this has resulted in, there was a recent study looking at trauma centers in the United States and finding that trauma centers that have emergency medicine training programs at them have significantly lower rates of complications of the care that's delivered, as well as significantly lower rates of mortality, as well as hospital length of stay. And so, we could ask, why is that? And I think part of it is because of the improvements in education and training that are specific to the care delivery, and I think some of our other colleagues are going to talk more about that. Part of it is because of the supervision that is now happening on more of a regular basis. But I think importantly, the focus on processes and having safer processes of care has been a big factor in this. And what I wanted to just briefly touch on were a couple of these process improvements that have contributed to this. So one of them is what we call computerized provider order entry. And this is a relatively high technology solution that has been, some of the pioneering work showing the benefits of this was done at the Brigham and Women's Hospital in Boston, where I now practice. And but this approach has become, I think, increasingly incorporated into informatics platforms in a variety of settings. The work that was done at Brigham involved the implementation of a computerized system whereby physicians would order their own medications for patients that they were caring for, rather than either writing the orders down on paper or verbally communicating them to nurses or others. They, in the process of doing this, would use an application that was implemented, in which they would indicate the dosage, the route, and the frequency of the medication, and then they would be prompted with a number of other pieces of information, which could include relevant laboratory values, say, for example, what the patient's potassium level is if they're ordering diuretics, if there are any allergies that the patients may have, any drug-to-drug interactions, or any subsequent orders that they might want to consider. For example, if they were ordering an aminoglycoside, to prompt them to order a level of that, and so on. And so this platform was introduced over a 15-month period. The first 6 months were a baseline data gathering period, and then the subsequent 9 months were a post-implementation evaluation. And this system was implemented randomly to randomly selected medical and surgical departments, as well as ICUs and non-ICUs. And the results of this were quite remarkable. It was found that the incidence of serious medication events was reduced by about 56% over this time period as a result of this intervention. And the non-intercepted adverse drug events were reduced by 84%, which I think is really quite remarkable, and a sort of a testament to what can potentially be accomplished. Interestingly, when you break these down, it was about 20% of the reduction in errors were related to the ordering of medications. About 84% were related to transcription of these, and about 50% were related to the delivery or the dispensing and then the administration of those medications. So that's an example, I think, of a high-tech approach, but there are also some equally effective low-tech interventions that there's been really good evidence that I think is applicable. The greater implementation of standardized processes, I think, is well known to be an important factor in improving patient safety and improving quality. And another pioneering effort that was started at the Brigham and Women's Hospital and run from there was the implementation of safe surgical checklists, an effort that was led by an endocrine surgeon at our hospital named Atul Gawande, who has written a great deal about the benefits of these. And this project was one which was based on the WHO recommendations for best practices for safe surgery. And they developed a 19-element checklist that was involving the major areas in surgical procedures where complications are known to arise, including the delivery of anesthesia, the prophylaxis of infection, and as well as effective teamwork. And the different time points when the checklist was implemented were before anesthesia was administered, immediately before the incision point, and then before the patient was discharged from the OR. And they carried out this study in 8 different hospitals in 8 cities that corresponded to different regions, the different WHO regions, and a total of about 7,000 patients in the before and after period were included. And simply through the implementation of this checklist, there was a reduction of nearly a third in the overall complications as well as the mortality rates from this. And I think this speaks to the power that sometimes very simple process improvements that standardize the delivery of care can have. And I think that, in summary, I would just say that I think, there is an important role both for high-tech as well as lower-tech strategies, and that important improvements in patient safety and care are absolutely achievable.
Thank you very much, Rand, for this very, enlightening coverage of the role of technology and also using, as Dr. Patrick said, simple measures like surgical checklist, but it has a high impact on reducing the medical errors by third. I think this is very interesting. Now I'll move to Dr. Ahmed Al-Amri, who will also cover the experience in National Guard Health Affairs, and will also probably shed the light on the proposed National Safety Center, which was declared a few weeks ago. Dr. Ahmed, please.
Thank you, Dr. Nahar. Dr. Nahar says that I work at the National Guard Health Affairs. Show of hand, who works at the National Guard Health Affairs? You can go for a coffee break. So anyway, our system, just a brief about it, it's 5 hospitals across the kingdom, and we have about 70 primary care centers, and plus a health science university and a research center that is attached to it. And I was fortunate enough to be selected by the forum, and I'm very happy to be among colleagues that talks about a very dear topic to mine. I came in touch with patient safety back in the early 2000s when I was doing my master's degree, and I was fortunate to have a professor who actually is specialized in system engineering and soft system theory, and he was talking about the effective system on safety. And then at that time, the movement had already been started by the IOM reports, There is Human, and Cross the Quality Chasms, and then we came back to the National Guard, and then we started to work on some initiative. And so I was given the task to talk to you within 10 minutes about some of the challenges in relation to patient safety, and then talk about some of our work as part of the healthcare system within Saudi, and then maybe shed light on the new patient safety center that was initiated by the Minister of Health. So basically, when it comes to challenges for building a safer system, there are specific building blocks that I want to talk about, and then I'll talk about how did we address them there. So first of all is the structural issues. I think there is no clear way of how to structure quality among healthcare organizations at the moment. We don't have a really clear areas. We have great success stories of organizing services when it comes, for example, to cardiac sciences or emergency departments. But when it comes to how do we deal with quality within an organization, do we do it centralized? Do we decentralize it into units? What's the role of the microsystem where really the sharp end works, and what happens in the blunt system where leadership works is a major issue. The other part is in terms of structure, is the IT infrastructure. Quality and safety is based on data, as Patrick have alluded to, and if you don't have data, you can't manage the whole thing. And so IT gives you a valid, robust data in a lot of circumstances, and unfortunately, we can't go with current IT system as granular as we want. We still reside in manual and analysis and all of that, and that's a major issue in relation to it. The other thing about the structure, I think that, and my colleagues will speak about it, is that as healthcare providers, we're trained to take care of an ailing body of a human. The problem is we are tasked to also heal the ailing system, and those requires different skill set. How do you handle that? And what is the competency when it comes to leadership within that field and managing that field? The other aspect which Dr. Nahar alluded to is the importance of culture. I think culture is a very, very important concept, and there are a few parameters within that, issues related to leadership and just cultures. We still, in a lot of healthcare organizations, we have autocratic leadership that isn't not. We don't have a lot of touch with the sharp end and the difficulties that people face when taking care of their own patients, and that's an issue. The other part is the legal aspect of how do you handle safety. I think our colleagues in the US know the issues of the suing environment there and the lawyers. We have issues similar to this. How do we handle this? Where does the system responsibility stops and then the accountability, individual accountability starts? And where to draw the lines between those two is an issue. Teamwork, we still organize our services around apprenticeship, around people, around basically providers, rather than creating a patient-centered care. That's another issue, which led, of course, to teamwork issues, to communication issues, and all of that. The other parameter is the learning system, a systematized way of analyzing problems, learning from them, and improving them, which also requires transparency and also requires competency training in some of those elements that we do not really get in touch with it when we are doing our basically majors. I was not taught during my medical school, and I don't think anyone here was taught about improvement science or SPCs, and so those are issues that are difficulties and are facing us and are facing the world. I don't think we are a stranger to the world when it comes to that. I think I'm going to go to how did we handle some of those aspects, and then I'll talk about the concepts in relation to it. And I hope that I'm going to touch some of those elements, some of those challenges, and how did we handle them. So leadership was a major issue when it comes to quality and safety. I think in the National Guard we're so much privileged to have leadership that are conscious about the elements of system impact on harm, rather than the blaming culture. We know that we are in a very complex industry. The almighty Apple, a $700 billion company, produces 6 products, I think, or 5 products, and then with the Apple Watch they have like 6 products. all of their power, mind, might goes into those. We have 13,000 plus diagnoses. Each one of them has different iteration based on the patients. We have more than 4,000 procedures. We have more than 300,000 pharmaceuticals. And then all of this within a system that have specialties and subspecialties. In our institution, we have 110 divisions that handles this in the clinical areas. And so this sort of complexity raises a lot of issues. And so in leadership aspect, I'll give you examples of what we did in the National Guard. So one of them was the issues of how does the board or the governing board really deals with quality. So it becomes part of our standing agenda to talk about patient safety issues, sentinel events, trends. In any given meeting, there is a start of that meeting with this sort of creating an environment where giving back people an idea that we are in the business of providing care, and then we are in the business of providing safe care. And so I think that we have done this fairly well compared to other organizations within the region. So that's one piece. The other piece is the sort of the accountability piece when it comes to leadership. I think that the leadership within our institution have dealt with that. So a lot of the elements related to accreditation, to patient safety, goes immediately through the channels up to the CEO of the organization and the chief medical officer and myself. And this creates a lot of sort of accountability when it comes to the care. The other part is the restructuring of quality and safety. Recently, we have decided that we need quality and safety to be sitting on the top of the system rather than to be just on the microsystem or the institutions or the hospitals. So now the quality and patient safety has a corporate department that handles all the 5 institutions and the primary health care, which is a big movement and a big challenge. And it's all the report to the CEO, which is, I truly think this is the way of the future. I think quality should report to the highest ranking officer of the organization, which is an extremely important thing, and it's usually not done a lot in a lot of the organizations. Usually quality is a department that get known when accreditation happens. And suddenly all of those people come out of their offices and started to be known. So I think that's a very important thing. The second element that I want to talk about is safety culture. I think safety culture is a major issue. We knew from aviation industry that you can measure culture and you can alter culture. It is not just this sort of term that nobody can measure or can alter. And we have underwent a measurement of safety using a tool called the Safety Attitudinal Questionnaire that was validated by a guy named Saxton out of Texas Science. And the element itself, we just recently finished that. And we are, in terms of our cultural survey, shows that we are basically in what they call statistically the danger zone. It means, translate into, we have a lot of work to do. And so in domains like safety climates and safety culture is I know most of you know about that, but it has 3 elements related to it. It has elements related to how do people practice in the real world, and what is the stated values, which is usually the sign that you hang on the wall and say, this is the values of my organization. And basically the assumptions of people, and it goes through that through a survey tool. And so after the measurements, we found that we actually have a lot of elements that we have to focus on during the next few years. There was one study that was published in 2009 that looked also at a mixture of governmental hospitals and private hospitals, looking at the same topic about cultural survey, and it was published in the Quality and Safety Health Journal out of the BMJ. And it's also highlighted those issues that we have issues in relation to teamwork, safety climate, as foreseen from providers. And so that gave us the basis of where can we move. Then we did a systematic debriefing that we looked at units itself. and we asked them to elaborate on those sort of experiences, and there was a lot of elements. One of the biggest elements that we found in relation to the culture was the just culture. How can I feel safe if I report a medical error, that this error will not reflect on my evaluation or it will not reflect on me in terms of my status as a clinician, as a nurse, as a physician within the healthcare team. So what happened is that over the last few months, we are working on a framework in terms of just culture. James Reason, who actually revolutionized the safety science, brought it to healthcare, and everyone maybe knows the Swiss cheese model. James Reason came with that, worked on a 5-question element relation to a decision tree to outline system versus personal accountability. David Marks, who's an American engineer, took a look at that, and basically he came up with a framework that we are adapting at the moment. And one of the things that was amazing is that we took that policy, most of the policies, and if you work in organizations, there are a lot of pages, nobody reads them, and basically it gets signed, and then when accreditation agencies comes in, you just take them, wave the dust, give it to people to read them. But what happened was with this policy is that we send it to every member of the organization. I asked them, how would you like to be treated? That's a just culture. If you report harm, this is the way we'll do it. Do you think it's good or not? And we had a lot of great feedback from people who are on the ground, people who are going to report. And so that's a big movement to really move into the just culture element. The other part was the reporting. We have issues related to reporting harm. You can cut me off, Nahar, at any time.
Yeah, in fact, probably we'll cover this part and leave the other theme, which is the national center for the next session.
So I'm going to talk about just reporting elements. So when we started, we studied our reporting culture there. We had, if you look at the organization, studies have shown that the reports depends on culture of the organization. So we have organizations that have 0.4 reports per 1,000 patient days, up to 140 plus per 1,000 patient days of published literature. And so we used to have paper. Our reporting rate was around 5 per 1,000 patient days. So we moved into an electronic reporting system in 2009 in the central region, and then we moved it across the whole system since 2013 till now. We're totally electronic. Our reporting rate at the moment is around 30 per patient day, so this is about six-fold increase. So we're sort of in the middle range. Now, the biggest problem is the ratios of no harm to harm. No harm to harm meaning near misses for a big injury. If you look at industries like chemical industries, and if you look at nuclear plants, they have about 620 to 1,000 near misses to one actual incidence. And that means that they are so vigilant. They're preoccupied with failure. They look for things. Mm-hmm. For us, at the moment, we have increased that rate from about 5 to 1 to about 7 to 1, which is moving very well. So I'm going to leave that.
Yeah, thank you very much, Dr. Ahmed, for this very informative description and reflection on your experience in the National Guard. Now I will move to Dr. Khalid Al-Gmeizi, who will also cover the role of undergraduate and postgraduate training in improving the safety culture among the healthcare workers or professionals. Dr. Khalid.
Thank you, Dr. Nahar, for giving me this opportunity to talk about the Saudi perspectives of patient safety and in terms of undergraduate medical education and a little bit about the postgrad. In fact, the issue of patient safety has been addressed among the medical schools early in 2005, has been formulated by the initiative which has moved to establish the Saudi framework. And since then, it has been accelerated by launching of the WHO patient safety curriculum. In 2011, the Saudi MEDS framework has been launched with 7 domains, and the patient safety was put in the center as a core issue in the medical curriculum. The last edition of the Saudi framework has highlighted the importance of patient safety in medical curriculum. And that should be reflected in the curriculum content and the assessment. And it's going to be incorporated in the Saudi medical licensing exam as one of the competencies that should be tackled and should be addressed. The current situation now, since dissemination of the WHO curriculum, most of the medical college has adopted that, but in different way. Some of them have dedicated program, almost 5 medical college in Saudi Arabia, and the majority have embedded the competencies within the different rotations. But yet even the WHO curriculum, most of the assessment of the outcome was short term. It's about 1 year. It's about the assessment of knowledge and the skills acquired. But what is the real impact of such program and curriculum on the medical care and medical services? I think it's early to judge upon that. The WHO is a generic curriculum that can suit and fit with some modification for most of the health profession, not only for medical college. Adapting such program also carry different challenges. I mean, like the limitation of resources. The vast majority of medical college who have adopted that program, they have mentioned the limitation of resource as one of the biggest challenges that they are facing. Because when they have assumed that the practitioners are aware of that, they were really shocked by the result that most of the people who are practicing, they are not competent enough to teach the patient safety issue. The other one is the limitation of resource, time, place, resources, where is the metaphor of the teaching take place in the college, in the hospital, different hospital cultures. All this has contributed to diversity of the application. But overall, the WHO have revised and took a feedback from most of the medical schools who have adopted that curriculum. The overall, in terms of knowledge and expansion of collaboration, directing and the attention to patient safety was positive, and almost the range from 85 to 95%. It has driven their assessment to that important issue. All of them, they have acknowledged the importance of patient safety, and it is a really generic curriculum that can be utilized in every specialty. But as you advance for the subspecialty, of course, there are a lot of variation that can take place. In the last edition of the Saudi framework, they have highlighted certain important issues like addressing and demonstrating the knowledge and skills in the area related to patient safety, like root cause analysis, safe prescription, and safe procedures. Also dealing with the aftermath in both the doctor and patient, demonstrating the reflection and the learning from errors, recognizing and managing clinical risks. Also applying the essential principles of infection prevention and control, plus reporting any concurrent physical and social and mental ailment. And this is a very important issue that should be addressed, because we are facing a big challenge in what do we call, awareing the people that the importance of reporting when they are sick. And probably we have noticed that in Corona and Ebola, that failure to report sickness has led to the progression of the problem. I think in the medical school also what is required is not only implementing, also re-evaluation of their strategies, re-discussing that one to reach to the best practice according to our local requirement. The contextual approach, because patient safety related deeply to the context and to the culture also. These challenges should be addressed and are going to be reviewed with reviewing the competencies. Definitely there will be variability in the application and the assessment, and but all these tools should lead to what is expected, a similar outcome in the medical schools. For the postgrad, the Saudi framework was generic, that can be applied in the undergrad, postgrad, and even for the continuing professional development. And the patient safety also has been tackled in the Saudi Commission for Health Specialty as one of the core competencies and should be tested in every specialty. It has been demonstrated in the blueprinting of the exams and assessment. So I think that the future is promising. What works best? It's not yet clear whether it is embedded or solo. Blended curriculum or blended courses where there is a solo induction or independent induction course with blended or embedded lectures and skills with different rotations. It seems the best if the available resource permit that.
Okay. Thank you very much, Dr. Khalid. Now we'll move to Emilio Lopez, who is coming from administration background, and he will emphasize the role of communication among healthcare team in improving the patient safety. So please, Emilio.
Thank you so much. Can you hear me okay? I want to start by thanking Ransel Potter and C3 for the invitation. It's wonderful to be here. Contrary to my colleagues in the panel, I'm an administrator, I'm not a doctor. And I think that's an interesting point following on what a speaker was saying on the previous panel about the need of increasing the training of a multidisciplinary team where we are only not thinking just of the doctors and the training and continuing education of doctors, but what is the role of nurses, technicians, and in my case, administrators. I was very lucky early in the 2000s. I worked for Johns Hopkins in Baltimore. And I say I was lucky because I was part of quite a movement that originated in Baltimore called patient safety. And the watershed moment at Johns Hopkins coincided with two sentinel events that we had were very public and notorious. One of them was the death of a healthy employee of Johns Hopkins who was a part of a clinical trial, and our colleague passed away because of an interaction of the drug that she was taking that had been previously documented but had been missed by the researcher. The second one was a very moving case of a pediatric case of a kid who died at Johns Hopkins because of a medication error. The name of the kid was Josie Keane. To this day, everybody who worked at Hopkins at that time remembers that day. The chairman of pediatrics came to the house of the parents to apologize personally. And the mother was so moved by that gesture that took the money from the legal settlement and reinvested into a patient safety program at Johns Hopkins. So that was a quite incredible story, and the mother is to this day a patient safety advocate around the world. One of the things that I really loved about the Hopkins experience was, again, how administrators and nurses were made part of the movement. We were part of cross-functional or cross training with, for example, as we were saying before, teamwork and communication. We learn a lot from the aviation industry. We brought best practices on multidisciplinary teams from the aviation industry, and we were all part of that. A lot of the training that happened at Hopkins at the time, and I believe continues, is general mandatory training. As all of you know, that those of you who are in hospitals that have gone through Joint Commission International Accreditation or are in the process, patient safety is very high on the agenda of these international standards, and it's definitely in the United States in our Joint Commission as well. And it's the same way that we all get trained about fire safety or infection control, basic infection control. Patient safety is something that I feel that it's important for everybody in a hospital, no matter at what level, to be trained on. From the people who clean the floor to the people who prepare the food, to, again, anybody on the front line will have a role to play in patient safety. And I think it's important to receive from our leadership the mentoring and understanding of what is our role in the scheme of things within patient safety. Going back to the role of the administrator, a little more about that. In terms of leadership, I have a few examples of things that I really learned from at Hopkins during my time there. One of them was this idea that the dean of the School of Medicine, every time he spoke in public, the first thing he talked about was patient safety. That was always the first theme in his agenda, and that created, that really helped create that safety culture that we were talking about. Another thing that I thought was very helpful, all the C-suite at Johns Hopkins, each one of them adopted a unit that was believed to be at danger for any reason. For example, as we know, ICUs are fantastic place to start doing patient safety interventions, because ICU patients are the sickest and most vulnerable. So each one of the members of the C-suites and the vice presidents adopted a unit and spent bi-weekly rounds talking to the people in the unit about what were the patient safety concerns, what do you need that you're not having, and that helped create a trickle-down effect. And the administrators from each one, from IT, from human resources, from each one of the administration leadership, were involved in this adopting of unit interventions. Another one very interesting is that we were having a problem in the ICUs with following the standard protocol for insertion of the central line, and that was creating more infections, obviously, that needed. And the nurses complained that the residents were not following the protocol properly. And the president of the university, who had adopted one of these units, when he learned this, he gave the nurses his phone number at home, so the nurses could call him personally if any resident ever again will break the standardized checklist to insert the line. You can imagine after that happened how many calls the president got at home, right? How many more times we had. And that particular unit demonstrated an incredible improvement with 0 infections for a really long time. So that was another interesting case. Following what my colleague from Harvard mentioned, I do believe that patient safety could have low-tech and high-tech interventions. He gave wonderful examples of both, and I wanted to give you a couple more that I've seen through the years that I thought very valuable. One of them was another checklist. It's a one-page checklist that has become an international standard in ICU care, and that was originated at Johns Hopkins, and it's a piece of paper. And that simple checklist has shown an incredible impact of the patient safety of these very vulnerable patients. So I guess the lack of resources cannot be an excuse at times. There are very low-tech, cheap or free interventions that we can do by printing the proper materials out of the internet for our teams. And in terms of high-tech, at the University of Chicago, we're pioneering one that I'm very interested in because it goes beyond patient safety to be preventive or proactive. And this is a new model that has been developed by our doctors that has an algorithm that predicts the risk that an inpatient has of suffering a heart failure. So through that algorithm, we have 2 registered nurses who round through our hospital with an iPad, and there is a queue that shows what are the patients in the hospital at the highest risk. So those patients get extra rounds from these nurses, they get checked in. We make sure the carts and all the technology that we need in case something happens are close by. And I thought that was an interesting new model where I think this big data is starting to prove very interesting. Where thanks to the electronic medical records, now we're able to put together all this information, medical records. I lost my microphone. No, there we go. All the records from patients, so we can create algorithms and we can learn from the past to prevent futures in the problems in the future. One last thing I wanted to comment. I'm from Spain originally. That's where my accent is from. I'm from Madrid. And unfortunately, recently my father was sick and I was visiting Spain, and I thought a lot about what I had learned at Hopkins and what my dad was not getting in this very famous academic medical center in Madrid. And how vulnerable patients are. For example, in our cultures, patients demand to stay in the hospital for a very long time, right? All of us have experience with that. Where in the United States, they're very strict about getting the patient out of the hospital as soon as possible. And that's something I learned, I think, at my time at Hopkins, that when I have a family member in the hospital, I really hope that they get out of there as soon as possible, because I do believe that hospitals can be a very dangerous place for patients if they stay there for longer than they need to be. Another thing too, in this academic center, there was 3 people per room. I could tell that the nurse staff was not properly following hygiene. Now they had implemented though the Purell in every door, so they were now cleaning with these products before coming in and out, but not all of them were following. My father is older and very sick, so he was very vulnerable for infections. So I think that none of us, administrator, nurses, or doctors, came into this field to hurt anyone. And I think this is why the patient safety movement resonates so much among all of us, and I think it's something that can bring us to the table no matter what. We can disagree in many things about many different things, but I think this is one thing we all agree on, and I think we need to leverage the consensus that patient safety brings to the table to implement a bigger quality agenda where we can move from worrying about killing our patients or hurting our patients, and we can move towards the goal of really getting the most desirable outcomes and the best outcome possible for our patients. Okay. Thank you.
Thank you very much for our speakers for the very interesting, informative coverage of these themes, and as we agreed, the safety culture, the technology use simple measures which can have a high impact on patient safety. The floor will be open now for 3 questions.
Assalamu alaikum. My name is Hanan Balkhi. I'm the Executive Director of Infection Control at the National Guard Hospitals. I think this was a very excellent session. I would like to thank you for that. Just a few comments and maybe additions to our experience in infection control, which is a cornerstone of patient safety. The elements from my experience in doing this for the past 15 years was really the ownership part. And I think a lot of the speakers have spoken about the leadership issues. The leadership needs to be understood from the organizations at the different levels all the way down to the frontliners. Very quickly, just an example in our ICUs, we've went for a full year in one of our most busiest intensive care units with only 2 central line infections. In the neonatal ICU. In the adult ICU, we went from 22 to 7 within 2 to 3 years. And the success was because the engagement of the frontliners, every single person's voice became listened to and heard. So I think that's something that we need to do. One thing that I'm happy that Dr. Emilio talked about and Dr. Gumezani is the data, is showing the rates of infections and being transparent with it. Till today, we still have a problem being transparent with that data. We're shameful of reporting it. We always feel that it reflects on something bad. However, if we do not reach the point where we can clearly report our rates transparently and understand that we do have a problem, then we won't be able to move forward. So I just wanted to share those simple thoughts with everybody that it can be done, and we hopefully will be moving forward with our patient safety agenda. Thank you.
Thank you for that comment. I would love to follow up very quick with that. Thank you for bringing the comment about the data and transparency. Actually, now in the United States, we're being forced to it. We went through from being voluntary about it and now being very clear public list of our hospitals that are not meeting the standards of lack of prevention of harm in hospitals. So it's very interesting. Thank you for bringing that. I think that that's definitely where we're moving forward. So our mission as leadership is to be proactive about it and be ahead of the curve and create a culture where you don't create a punishment with the numbers, but actually you use them as a way of tracking and being proud of your incredible results, for example. I hope that those incredible numbers that you share have been shared with the rest of the team as a motivator and way of being proud about your work. So congratulations.
Thank you very much. I think Dr. Ahmed wants to comment also.
Thank you, Dr. Hanan, for bringing that up. And I don't think anyone here really questioned the effect of data on the patient safety movements. I think Patrick spoke about the 3.7% of harmed inpatients through a billing system in the Harvard practice study. And now we see that up to 33% in the latest studies shows that the patient gets into the hospital or any healthcare system and gets harmed by it rather than the disease itself. So data is a very powerful thing, and I think it really, this sort of transparency and the validity of it and sharing it is the next step for us in healthcare institutions. Now we face difficulties here. I think the US also system is coming in term with that and publishing some of the data on their website. It's valid data. I think because of also the payment through the leapfrog group, and also there is a lot of pressure from insurers to really say and rank hospitals and give that information to people. That was a very important thing. I have a question, please, Dr. Khalid Gumezi, if I'm allowed to ask a question. It's the role of simulation in patient safety. Was that formalized in terms of postgraduate studies in the Saudi Commission? Was there a framework related to it?
Okay. Is it to Dr. Khalid? Yeah.
I think the simulation and its role in patient safety is very, very clear and well demonstrated in undergraduate and postgraduate. In most of the medical schools, they do have a simulation center with simulated scenarios to tackle these things. And according to the WHO curriculum, simulation is a core stuff that need to be adopted to imitate the simulation and make the student-patient interaction more safer and more convenient. For the postgrad, usually the hospital, they are not driven by, or they don't have the interest to develop the simulation center. But I think we have a big chance to have a national center where the student or the resident, they can go and fulfill a course that meet the requirement.
Okay. Any other question? Yes, please.
Thank you very much for the very interesting topic. My name is Rana Jibreen. I'm the Director of Patient Relations at King Faisal Hospital. Recently we've been seeing patients and family members really involved in patient safety. And they would raise their comments and concerns when something goes wrong, and they are key drivers in driving patient safety within our organization. And one of the reasons why they would raise their concerns is basically to make sure that these incidents don't happen again and other patients are not affected. And my question to you is, how do you see patient involvement and family members' involvement in driving the culture of safety within healthcare organizations in Saudi Arabia?
Okay, any of the speakers? Yeah, Dr. Ahmed.
Thank you very much for this very important question. I think that was, we were in Boston about a few months ago, and this question came up. How do you really regulate patient engagement? And what I meant by regulate is not really to put barriers. What I meant is to create a culture of learning, where we can learn from their experience in a very fruitful way. Now, there is no very specific way of doing so. I'll give you a few examples from the US, and then I'll talk about some of the things that we did. So in CHOP, for example, in the Children's Hospital of Philadelphia, they have what they call an employed family member. So they have 2 or 3 family members, and usually they are moms of chronic, ill, unfortunate children. They come to the hospital, they get engaged with do an investigation, with admission and all of that, and so they are employed. They're actually on the payroll of the hospital. And they serve to come to sit with the board, to sit with the with improvement teams to tackle issues. That was one model. The other model was a patient advocacy or a patient council, where there are a group of elected people from the patient who are coming into the system, and usually they are consulted when it comes to improvement and restructuring. This is, I think, Kaiser have done something similar to this, and there is a variations between all of those. Now, what did we do in our institution? I don't think we have a very clear way at the moment of how to do that at the leadership level, which means that getting into the board element. But I'll tell you what we do in terms of improvement science. When we do create projects that have a specific aim to improve care, for example, patient-centered care that we did recently to identify the most responsible individual of a family. We have large family in Saudi, and there is a lot of questions and how do we transmit all of these sensitive information about the patients and their outcomes. We conduct tests of change, and those tests of change, which are PDSA cycles, involves patients' opinions because they are part of that. And so the designing of tests takes on the opinion of patients. Would we love to see more involvement and fitting in that? Yeah, of course, that's a domain of quality, but we did not do it in a systematic fashion. I'm hoping that the next wave that we're going to start hopefully in May in our hospital that will shed light on how we're going to involve them systematically in at least most of the projects that we'll have.
We'll take the last question from Dr. Tawfiq.
Thank you so much, Professor Nahar Al-Hazmi. I just would like to comment on the last comment from the lady's side. I think this is an excellent comment, the involvement of the patients. Now, any healthcare system should be people-led rather than health professional-led. And this is an important concept, which is patient-centered concept and personalized care. So what she is raising is really a crucial component of any healthcare system. Unfortunately, the studies which was conducted 5 years ago by WHO in the Emirates state, in the East Mediterranean region, showed that involvement of the patients in healthcare in the Arab countries and North Africa is very poor. It is the doctors, the healthcare provider, who decides for the patient. And it was very clear in the study which was conducted 5 years ago and published in the East Mediterranean Journal about the patient safety culture. There was a recommendation by the regional director of the WHO that these countries, which Saudi Arabia, one of them, should look again about the involvement of the patient in patient safety issues. I think they are the best people who can teach the healthcare providers how to be more safer. And there are so many publications coming up in the last 10 years how to get safe from the hospitals. His Royal Highness Prince Mit'ab bin Abdullah bin Abdul Aziz asked me once, Doctor, we come to the hospital with one disease and we come out of the hospital with 10 diseases. So it is a concern of the community. So unless we address this one very seriously and not superficially, we are not doing much in patient safety. I think what is going on in the Kingdom of Saudi Arabia until now in patient safety is a slogan. It is not real activities. So we need to have a real approach towards patient safety and to change the movements of patient safety within the concept which was published in 2005 by WHO, World Alliance for Patient Safety, and 3 years ago, the curriculum of patient safety in the undergraduate, postgraduate. So it is a big issue, patient safety, and everyone in the Kingdom of Saudi Arabia, every society, every family has a problem with the hospitals, with the healthcare provider. I did a study in 1996 of medication in urban primary care. It was 5.6. My brother-in-law, he's the Director General of Quality and Patient Safety in the Ministry of Health. He did a PhD. After 10 years, it becomes 12% is medication error. So there is really a serious issue in this part of the healthcare system improvement. So I think unless we, I mean, we need to put the patient as a center of our work. And so we need to bring the patients together to tell us the stories, how we can be more safer in our healthcare. Otherwise, we are in the ivory towers, thinking about the patients with a lot of guidelines, GCI, Saudi Commission, Sibahi, and then the outcome is still increasing the medication error and malpractice and infection problems. Look at the corona and so on and so forth. So I think this is a serious issue. It needs to be addressed with, as a country-wise, not the Ministry of Health-wise. As a country-wise, a national body should take this one. Within this one, this body, the people rights, and the people should have a say in this because healthcare should be a people-oriented rather than a professional-oriented. Thank you so much.
Thank you very much, Professor Tawfiq. And in fact, I can't agree anymore. I know that we are also running out of the time.
Just a small comment.
Just 1 minute, please, because we have to.
I think an important issue should be addressed that we lack the data about death related to medical errors, and we don't know whether it is the leading cause or the second or the third. And we should really seriously develop a reporting system that address that particularly. Otherwise, all what we are doing is just blaming and assuming that this is due to that, and we don't have real data that could direct us for the future.
Okay. In fact, on behalf of the speakers, we thank you very much for your contribution and presence. And on your behalf, I want to thank our respected speakers for their informative and very interesting discussion. Thank you very much, and thank you, Ransel, for all.
So thank you very much, Doctor. That was a very interesting session. I think the audience took away a lot from it. I know I did. So now that we'd like to conclude it with giving some awards, so we're going to present to you first, Doctor.
Thank you.
Next, I'd like to present Dr. Philip Anderson, please. Next, Dr. El Amre, I'd like to present you. Next, Dr. Al-Gamazi, please. And Mr. Emilio Williams Lopez, please. Thank you. Our next panel will be on the future of primary healthcare, training and manpower, and it will be moderated by Dr. Mohammed Basalama. And if you all could come up, we'll get moving, and thank you again for your participation.
بسم الله الرحمن الرحيم والصلاة والسلام على خاتم الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Good morning. And welcome to this panel on the future of primary health care. I'm really delighted to see so many of you here, and I think that we will have a wonderful and interesting session with our eminent speakers who will have 60 minutes of challenging discussion, inshallah. However, I'm sure that in this hall we have many experts, many policymakers, academics, and administrators, and all sorts of people who can add and enrich our discussion. So by way of, quickly and by way of introduction, my name is Dr. Mohammed Basulaiman. I'm a consultant family and community medicine and quality improvement specialist in healthcare. And currently I'm occupying the position of Assistant Deputy Minister for Primary Healthcare in Ministry of Health in Saudi Arabia. We have here three experts in primary healthcare. I will try to introduce them the way they deserve. We have first on my left side, first seat, Professor Tawfiq Khoja. Professor Tawfiq is the Director General of the Executive Board of the Health Ministers Council for Cooperation Council States. And for those who don't know Dr. Tawfiq, he is a fellow of the Royal College of General Practitioners and a fellow of the Faculty of Public Health and fellow of the Royal College of Physicians. He has been awarded a professorship in health systems and quality from Oklahoma University, and at the beginning of 2010, he received the professorial degree from Imperial College in London. Professor Khoja is a family and community medicine and public health consultant, and he was the author and co-author of more than 40 books and manuals. He published more than 70 research and scientific articles in various international scientific journals. He has been awarded many local, regional, and international awards and recognitions, and he is a member of many reputable scientific societies. Next to Professor Tawfiq is Dr. Isam Al-Ghamdi. Dr. Isam is a consultant family physician. He got his doctoral degree in family medicine from King Saud University. He is Director General of Primary Healthcare Centers and Health Programs in Ministry of Health, Saudi Arabia. He is also Chairman and a member of several Ministry of Health national committees and a member of several regional and international committees. Dr. Isam was author and co-author of several primary healthcare manuals and published scientific articles. Next to Dr. Isam is Dr. Nuha Dashash. Dr. Nuha is a consultant family physician and a teaching staff at Postgraduate Joint Program of Family and Community Medicine. Dr. Nuha is also the head of research unit at the Family Medicine Postgraduate Program in Jeddah, and she is the founder of the Evidence-Based Medicine Working Group in Jeddah and member of Saudi Scientific Society of Evidence-Based Medicine and head of Jeddah branch of the Saudi Society of Evidence-Based Healthcare. By way, Dr. Dashash was the first ever Saudi woman to be appointed as Assistant Director of Health Affairs and later Director of Primary Healthcare. Dr. Dashash has several books and publications in the medical field and in general and in evidence-based medicine in particular. Ladies and gentlemen, please give our panelists a very warm hand, please. Thank you very much. I'll try to make this session as interactive as possible. I know that in this hall we have all sort of people who can add and enrich our discussion. So actually I've been requested by my boss, Dr. Tawfiq, to start with you. So I will start with a question for the audience, and then I will refer it to our speakers. Actually, there is a debate, and some of the observers have concluded that the case of primary care is lost because the road toward disease, specialty, and technology-oriented care has already gone too far in the direction of increasing market orientation, patient beliefs, and the satisfaction of the people, especially here in the kingdom, about primary health care and primary health care physicians All these questions lead us to ask, what do you see about this, and what is the evidence on the importance of primary health care? Please, if you have any comment regarding that, we'll start with you, and then we'll see if our panelists will add to that. Do we still need primary health care in Saudi Arabia in general? And
Thank you very much. سلوى الهزاع مستشفى الملك فيصل التخصصي ومركز الأبحاث. I guess what I have been preaching since I have been in the Shura Council, especially when it comes to the Ministry of Health and when it comes to the primary care, is why doesn't the Ministry of Health in the Kingdom of Saudi Arabia play a more pivotal role in the primary health care instead of putting its efforts, its energy, its finance into the specialized hospitals, which is somehow has not succeeded. If every place, if a person, instead of having to wait in line, I'll give you a simple example, someone with glaucoma has to wait 1 year to get into the KK, the King Khalid Eye Specialist Hospital, where they can very easily have a dispensary where a simple procedure of measuring their eye pressure, doing a visual field, and continuing, we would not be running into the crisis. And I'm sorry to have to say that. The crisis that the Ministry of Health at the moment right now is running into. Since the late King Fahd in the 1980s, he said the primary health care is important, the Ministry of Health. We have actually treated and actually managed every single ministry except the Ministry of Health. And if we would take his words and put them on today, which is what, almost 3 decades, it's like the late King Fahd is talking today. So I guess I'm very happy with this session. I'm hoping to God also with the change in the ministry that has happened today, that there will be a more pivotal role for the primary health care and to actually be able to serve each and every single Saudi within their community, within their living quarters where they live, rather than having to wait for these specialized hospitals, and where unfortunately it has failed in our country. Thank you.
Thank you very much, Dr. Salwa. So you think that the primary health care wasn't given the chance really to provide its services, and the real direction is to invest more in primary health care rather than going to specialties and building more and more hospitals. And Dr. Saleh?
بسم الله الرحمن الرحيم. Dr. Saleh Al-Ansari, Family and Community Medicine. I see that the pyramid is inverted when we are talking about how health resources are spent. And when we see 90% of the population treated by 10% of the resources at the level of primary health care, where we spend 10% only, or maybe less, on primary care to treat or to manage more than 90% of the population. If this pyramid is kept inverted like this, we will go to nowhere. And if we are talking about millions and millions of sick people who are living in the country with minimum prevention, minimum health promotion, minimum health education, I think that the future is not so bright. Thank you.
Thank you, Dr. Saleh. Actually, Dr. Saleh and the audience, 55 million patients are seen yearly in the primary health care centers in the Ministry of Health, compared to 11 million seen in the hospitals. So this constitutes more than 75%, and it's clear that to invest on 75% and put most of our budget to serve these people is more beneficial than investing in hospitals. Any other comment, please? If no other comment, I will refer first to Dr. Tawfiq to comment also on this point.
Bismillah ar-Rahman ar-Rahim. In the name of Allah, most gracious, most merciful, Dr. Muhammad Umar Bas-Suleiman, my respected colleagues, audience organizer, thank you so much for inviting me. And I just, I think 3 days ago or 4 days ago, I read a 1-page article Professor Salwa Al-Hazza. I was totally amazed and taken by what she wrote in that article in, I think, in Riyadh or Al Jazeera newspaper, and I kept this article. I know her very well, and how she is near to the patients and to the consumers. She was a doctor of my father, and my father said, "This is the real doctor." He said that to me, and she was so much near to the patients, taking care of all aspects of the patient, not only for the disease. So since that time, I respect her and I respect her work. Dr. Saleh Al-Ansari, thank you for the comments, both of you. I think what you have said is the right answer, Dr. Salwa, Dr. Al-Ansari, but reality that there is a loss of vision of primary health care in the Kingdom of Saudi Arabia. And even with all efforts put in the Kingdom of Saudi Arabia by the Minister of Health, still it is fragmented healthcare. There is no one language by all healthcare providers. Only the Minister of Health speaks by herself. And the Minister of Health, as Dr. Saleh said, is mainly concentrated on the, if it is not mainly, it is more than mainly, it is almost 90% in hospital care and tertiary care. Look at the movements towards specialization. If you see the investments in primary healthcare personnel is negligible to compare with the rest of the specialization. Unless there is a serious movement towards taking care about specialization in primary healthcare in all cadre, not only doctors, pharmacists, nurses, health educators, health visitors, clinical psychologists, and all of these people who are really needed in the primary health care, we are not doing much. There is an article, 7 articles written 10 years ago by Barbara Strafford, late Barbara Strafford, about the re-engineering of the primary health care in USA and over the world. And then 4 years ago, WHO came out with a book called Primary Health Care More Than Ever. And I urge you all to read this book. It is a very well written, and here the WHO say that it is time for all countries in the world to learn that the mistakes is huge, to invest in more hospitals. This does not mean that to ignore the hospital, but more hospitals, to be a disease-oriented rather than a healthcare nation-oriented. And this is, I think, why we are not achieving the targets with all investments. When I was in the Ministry of Health, the budget was 13 million Saudi riyal. Now it is 130 million Saudi riyal, almost. And it was going in the right direction at Al-Mani, His Excellency Dr. Hamad Al-Mani. It was going in the right direction for primary care, and suddenly things changes. So I think if we want to reorient the pointers of the Ministry of Health and other health sector, we need to have primary health care as a national project that the governments should involve by all its departments, all its ministries in the primary health care, and to look at the primary health care as a public health issue, and to look at the primary health care as the health of the nation rather than as a project at the Ministry of Health. This is my perception. We did in 2008 with Professor Salman Rawaf, Montegot, Professor Richard Hobbs, Michael Kidd, the leaders of the world. They came here in Saudi Arabia, and we did an investigation and in-depth appraisal of the primary health care, and we came out with a document, very clear document, about the future of primary health care in the Kingdom of Saudi Arabia. But the process of taking the recommendation was very slow. The allocation budget is not enough for primary health care. The personnel needed for primary health care is not enough. The Saudi Commission for Health Specialty does not open more training center for doctors. The training for nurses for primary health care is not there. The training for pharmacists for primary health care is not there, and so on and so forth. So I think we want to do something. We need to do a health sector reform based or led by the primary health care rather than led by a surgeon or intensive care approach. It is as Dr. Salwa said, we need promotive activities, we need preventive activities. It is enough for us that 28% of our adult people, they are diabetic. We cannot build every corner diabetic center, but we can utilize the primary health care center if we upgrade the primary health care center by resources, by human resources, by equipment, as it is in UK, as it is in Australia, as it is in Netherlands. We can bring the right direction of the primary health care in the Kingdom of Saudi Arabia. So it is this area, Dr. Muhammad and my colleague, is very dear to me because it's my specialty. But if we look to Oman, why Oman is ahead of us? If we look to Bahrain, why Bahrain is ahead of us in primary health care? Just recently I visited Kuwait, it is ahead of us in primary health care. I appreciate that Saudi Arabia is a huge country, but the location budget is not as compared for Oman in the primary health care, is not compared for Bahrain for primary health care. So this is an issue, is a serious issue. If we continue like this in Kingdom of Saudi Arabia, whatever hospital we are going to have, whatever bed we are going to have, will not solve the real needs of the patients, the real needs of the consumer, the real needs of the citizen and people who are living in this beloved country. Thank you so, Dr.
Thank you, Dr. Tawfiq. So you think that the only way forward for our healthcare system is to invest more and more in primary healthcare and have multidisciplinary teams, qualified multidisciplinary teams in most of our primary healthcare centers?
Yeah, I think, but also I am very pleased Dr. Salwa she is here. She's part of the Shura Council, and I hope other people that are here. Excuse me for this, Dr. Salwa. I think you put this as a top priority in health of the nation. That where is the health system going to lead us in the Saudi Arabia? We need to revisit the whole system of the Saudi Arabia. Okay, the 13 strategy which has been agreed by late King Abdullah bin Abdul Aziz in early appointment as a king, as a custodian of the mosque. It was clear the role of the primary care. Why it was lost after that? So again, so we need to have a KPIs from the Shura Council for all sectors. Why we are not doing the right job for primary care? Thank you.
Thank you, Dr. Dr. Sam, would you like to comment?
Thank you. I'm Dr. Assam Al-Hamdi. Thank you for the organizers to invite me in this panel discussion. And I agree with Dr. Tawfiq. We have to have more investment in the primary care centers and the primary care because it is the base of any nations. Unless the primary care is leading the health system, we'll spend more money and more cost it will be spent in the hospitals and will not reach our target for the health of the nation. If we are talking about the health, we have to have the primary care in place. If we are talking about disease management, it's okay to have hospitals. So we have to have a more primary care-led system with more finances and more separate kind of organizations. Like Qatar, for example, they have, although they have not so many centers, they have separated an institution for Qatar Foundation that they have separate primary care center, primary care sitting, so they can have move freely regarding the fund. And the main issue actually, I am in the Ministry of Health for the last 6 years in the primary care. And the main issue actually in the Ministry of Health actually is funding, this is number one, and manpower, mainly. And we have increased, for example, it was several issues actually in the Ministry of Health a few years ago. One of them is the accessibility of service. We have expanded the primary care centers from 1926 primary care centers, and it will reach within 2 to 3 years from now 2,800 to increase accessibility and equity of service all over the kingdom. There was a strategic plan actually from 2010 to 2020, which is it was GCC led strategic plan, and we adapt this strategy, and we are in the 5th year for implementing. The first priority was in this strategy actually in first phase. It was for the first 3 to 4 years is the infrastructure, because we were having more than 85% of primary care center is rented and not suitable to provide services in the primary care setting. So we invest more time in standardizing the classification and equipment and the manpower to be standardized with the Ministry of Finance to have these kind of centers. We have built more than 850 primary care centers, new ones, and 800 in the pipeline. And the rest, comes for the rest of the primary care centers. We have problems with lacking of lands to have primary care premises. We have other obstacles in this area. Regarding the services in the primary care centers, we have to have a balance actually between patient needs, expectations, and the essential packages that has to be delivered. So we have to build a kind of balance to be person-centered kind of services approach, and at the same time to be cost-effective in a manner of providing the services. So when we're talking about this, we are talking about manpower, what kind of services, is it preventive, promotive, curative kind of services? So we have to redefine for the next era of the primary care centers in the kingdom, because we are moving from developing to developed countries. We were having like the back more infectious disease. Now, as mentioned by Dr. Tawfiq, it's more NCD, non-communicable disease, cancers, ischemic heart. So we have to make the shift from the previous objective with primary care center, vaccinations, well baby, antenatal care, and general clinics, common diseases, to more sophisticated kind of approach and person-centered approach. But we have to have the right people, like family physicians, social workers, psychologists, all the health educators, and this we are lacking at the present. What kind of services? Is it preventive, promotive? Is it periodic health examination, elderly health, adolescent health? All these kind of programs has to be implemented and integrated with family practice approach. Lastly, regarding the KPIs and the performance and monitoring evaluation of the system, it has to be in place with a good health information system and electronic health record in place, which is we are lacking nowadays. Thank you.
Okay, thank you very much, Dr. Isam. Dr. Noha, do you have anything to add, please?
Yes, thank you, Mr. Chairman. Thank you, Dr. Salwa, for you really diagnosed the problem of health system, the main problem in the healthcare system in Saudi Arabia. I just want to add one single thing because you've covered most of the points. I think that we should go to the root cause. Why is primary health care denied its magnitude and its rights of being the main health care, the foundation actually of the health care? I think it's because at the head of the pyramid, we're not looking at health of the human being. We're looking at diseases. We're saying, well, we have a lot of cardiac diseases, we have emerging cancers, we have diabetes is a major disease here, where we're not thinking of the human being, the person who's suffering. I'm not saying the patient. I'm thinking of the human being who we don't want him or her to become a patient. But we should deal with those people as people before they come to us and after they come to us. All of the solutions through the years that I've observed, I've worked in the ministry for 22 years, and lately I've been in very close contact with people at all levels, people who have health insurance, people who don't have health insurance, and people say, well, Noha, you're a family physician, so what do we do with this and where do we go? And they get lost in the system everywhere. Whether even those who believe in screening and in prevention, they don't know what to do and where to go, and they get lost. So focusing on health of the human being will lead eventually to supporting primary care. And not just primary care. Primary care is the first step and the foundation. But then if we don't link this to secondary care, be it private or governmental, so that the person doesn't get lost, because at many stages where me as a practicing physician, when the patient comes to you or the person comes to you as a human being and you screen and you discover a disease and you label that as a patient and then send him to secondary care, even if they're covered and go to private, they get lost again. So the main focus is, please, the new minister, I hope he focuses on the human being, health of the human being, this will lead to focusing on primary care as a foundation.
Thank you, Dr. Nahar. Dr. Tawfiq, you have final comment regarding that.
Thank you. I would like to bring a very serious issue and why we are so much caring about primary care and family practice. If it was well known for the last 10 years, a visit to the primary healthcare clinic costs £6, UK pound, okay? We'll go to any outpatient clinic in the hospital, it costs £60. If you admitted in the hospital for one night, it is between £500 to £1,000. If you admit in the intensive care unit, £5,000. So this is so what we cost, the cost in the, and if the more you give the primary health care, the involvement in patient care and community care, the more you utilize the hospital in a proper way, the more you less the burden to the hospital. The cost will be less and less. And it was seen by Barbara Stafford that with appropriate budget like UK, you give more health indicators than high budget with USA, which is hospital oriented and center of excellence oriented. So this is the way that if you give more primary healthcare oriented, Canada, Netherlands, Australia, and this is well written by Barbara Stafford. So the primary care will reduce the cost and more satisfaction.
And better health
outcome. And better health outcome. This is a three component came out from Barbara Stafford of more than 50 research done all over the world. This is one thing. The other thing that the lesser the patients, the lesser the malpractice, because the hospital, the more they are burdened by trivial issues, the more they are workload, and they bring more malpractice and medication error. So the investment in the primary health care is a core component in reducing the cost, satisfaction, better health indicators, and patient safety, quality, and improving quality and patient safety. So this is the approach that, as Dr. Al-Ghamdi said and Dr. Noha, that the new minister, I hope he will take this direction as a serious matter in the health of the nation of the Kingdom of Saudi Arabia. Thank you.
Thank you, Dr. Tawfiq. Actually, if we look at the national health strategy of the kingdom, which was approved by the custodian of the two holy mosques just 3 years back, it is indicated that primary health care should constitute the cornerstone of the healthcare system. What we need is how to implement that, how to transfer it into reality. Dr. Tawfiq, looking at the current picture of primary health care in Saudi Arabia and the innovations and renewal of primary health care all over the world, how do you see, or what are the priorities that you think is essential to promote the primary health care system in Saudi Arabia?
Thank you. I think this again is a conference question. It is not. I don't know. We are going to have a conference, I think, in October. Am I right? In October, about primary health care, the future of primary care, and there will be another conference by Faculty of Medicine, King Faisal or Dammam University, and there is another conference will be in Qatar about primary health care.
Would like to hear the key initiatives that you think that it will change the primary health care.
Frankly, I think leadership is the first issue. Without having a real leader, advocates, people of with passion, and taking this as not a slogan, not a talk, it is a walk, it is a behavior, it is an attitude of that primary care should be their daily thinking. It's part of their heart, part of their cells to speak about primary health care. Prophet Muhammad sallallahu alaihi wasallam, his wife Aisha radiallahu anha wardaha, she said the behavior of Prophet Muhammad is the Holy Quran. See, if you want to see Holy Quran, see the behavior of Muhammad sallallahu alaihi wasallam. So in this respect, on this quotation, if we want to improve the future of primary health care in the Kingdom of Saudi Arabia, let us behave primary health care and be leaders of primary health care. And you cannot do it without training and see other experiences. We need to send people to learn from best practices in the world, why the Oman, they succeed. Why Oman in 2008, it was published in BMJ that let Britain learn from Oman. Why? Why not Saudi Arabia? So why? Because there's a leadership in this issue. Second is I think we need to improve the infrastructure of the primary health care. You cannot bring leaders and there is again the infrastructure of the primary care is a poor quality or a poor setting. It's not appropriate atmosphere for delivering the service. Third, I think we need to revisit, as Dr. Al-Ghamdi said, what's the mandate of primary health care in the Kingdom of Saudi Arabia? Ask the citizen, what do you need from the primary health care? Let the patient have a voice in this one. So we need to have a questionnaire through the Shura Council to ask people, what do you want from the primary health care? For the last 30 years, we are Minister of Health asking themselves within the cabinet with the Minister of Health what we are to do, what we have to do the community. Now it is time to ask the community. Fourth, I think that to improve the quality, even you have leaders, you have good financing, infrastructure, and you have the right mandate without proper quality in the primary health care. And I am pleased Dr. Sam Al-Ghamdi told me this morning that they are adopted the total quality management program in the primary health care. So I think this is the 4 or 5 top priority area to improve the patient satisfaction, to improve the outcome of primary health care. Other issue like referral system to improve the shared care between the hospital and the primary health care, the periodic evaluation, the opportunistic health approach, all of this it will come when we have the right leadership, the right budgeting, the right infrastructure. Thank you so much.
Thank you, Dr. Tawfiq. Dr. Isam, I know that you have a strategy for the next 10 years for primary health care in the kingdom. Can you tell us about the main policies in this strategy?
Thank you, Dr. Muhammad. Maybe I enlightened some of it, and it is for 10 years, started from 2010, and we are in the middle of it. As I mentioned before, that first one was mainly concentrated on the infrastructure because we're having a real problem in that area, but we managed to overcome maybe 60% of the issue. And actually we derived from this strategy actually maybe 69 projects, different projects in either in the quality, on the service provision, or in the standards of care. One of the issues actually in the quality, which is newly introduced maybe 3 years ago, I was head of the quality in SAHF-15 organization. We have developed like standards primary care centers, and it was 1.5 years ago it was adopted by SAHF-15 institution, and we are piloting that in 100 centers, 5 in each region, and we are in the real exam phase, and it will expand from there according to this capacity of SAHF-15 organization. With that, to keep the quality momentum, we developed it was actually, there is a quality assurance program which is implemented in primary care, led by Dr. Tawfiq previously, few years ago. But we renovate the issue regarding total quality management, including patient safety. And it just recently introduced the guideline, and it will be training workshops in the regions. We'll start also in the 100 centers. The issue is to have like a gold standard primary care centers, like a benchmark, so other centers in each region, they can look at it and to reflect on them how to improve from there. This is the standard of care that we want. But the main issue, actually, the major issue that we are facing now, as I mentioned before, is funding, which is obstacles most of the times, and also regarding the manpower. It's supposed to have, we have now in the future, we will have more than 2,800 primary care centers. We suppose that we have specialists and consultants in each center, family physicians. We have only 300, 400 like this. and we have more than 2,800. So we have a huge gap to have a quality of care. As I mentioned before, the diseases was communicable diseases, which can be managed by general practitioners. The expectation of people maybe a few years ago, maybe 20 years ago, was not that high now. Now we are facing dispensaries, specialist hospitals, so we are seeing in these institutions, private institutions, consultant and at least specialists. So the standards of people is coming high. And the primary care setting, on the other hand, we have 300 family physicians only. So we have a huge gap. The universities, the training institutions, they have to bridge this gap so we can reach the kind of care or standard of care. We can implement kind of services, a lot of services, quality, total management, accreditation, but who's the champion in the primary care centers? He's the family physicians. Unless we have that one, I think all our efforts, it might not reach the target as soon as we plan. So we have to have a fast or quick plan regarding to investing more in manpower, which includes also other specialties like psychologists, educational, because we have obese people. We want to go to diabetes, so we have to have more in manpower, investment in manpower in the primary care settings. And we didn't have that support actually, sometimes from the Ministry of Finance. So we have to concentrate in the primary care settings, as I mentioned, what is the target for the services, what was the aims for the health to reach, and then to have clear objective, clear projects to reach that target as soon as possible. We have posted more than 1,400 posts, specialists and consultants. We cannot nominate. We cannot post consultant specialists in primary care. It's vacant posts. Why? Because we search in the countries all over the country, here and international to have family physicians. It's a lack resource actually. It's a lack resource. So we have to invest more in training within the country. And regarding the services programs in the strategy, there is a lot of programs actually. Periodic health examination, one of the programs that we're implementing in 20, now implementing it in 20, which focuses in age-specific kind of approach for each age regarding evidence-based approach. And also elderly health program we implement in the primary care center. All these kind of programs is aiming to prevent a sickness of the people before they go to the hospital. So we minimize the referral to hospitals as much as we can. But as I mentioned before, who's the champion? The family physicians, the general practitioner. As much as you train him, he cannot cope with all these kind of activities and tasks to be implemented in the primary care setting. Thank you.
Thank you, Dr. Isam. Dr. Nuha, as you can see, as indicated by Dr. Isam, we have a severe shortage of family physicians in the kingdom. And family physicians are a key success factor for any primary healthcare system, I believe. So how can we overcome this challenge in the kingdom?
Well, that is very true, and a lot of solutions have come up. One of them was suggesting, and about 5 or 6 years ago, having a diploma program, which is a short program, to graduate family medicine specialists at a shorter duration. It's currently 14 months of training, and now the proposal is to move it to 24 months, 2 years. So that's a shortcut at least. But the main, being a trainer, a family medicine trainer for the past 16 years or so, the main problem nowadays is not as previous. Previous was, the main problem was medical students were not interested in family medicine. Now we have a lot of interested people, but we have no vacancy in the programs. The main reason for non-vacancy in the programs is because of the lack of training, vocational training spaces in hospitals. So because family medicine program is based on hospital vocational training, where family medicine residents go to most of the all of the major specialties and some of the less major specialties in various durations. So we want to send them, and the surgery departments say, no, we already have our residents, we're full, you can only send 2. Well, what do I do with my residents? So this has led to us rejecting. We get about, in Jeddah only, we get around 160 plus applicants, and we cannot accept more than 18 to 20. So And many of the ones that we reject are very, very enthusiastic and top students that we would not want to reject. We want this person to be the future family physician, but we have no vacancies because the hospitals refuse to take them in training. And so I think that we really need strong collaboration with the Saudi Commission to help modify the restrictions that we have for training centers. Maybe open the private sector for training, I don't know, but a lot of solutions should be found. Supporting centers outside the major cities. Like, for instance, the major programs are in Jeddah, Riyadh, Mecca, and the Eastern Province and Medina, but we need more programs in more peripheral regions where they have a lot of hospitals and they can, but these need support. And these people, to get trainers to go there, family medicine consultant trainers, you need motivation. You need to motivate them with payments, housing, whatever, but we really need to look at the major problem and find non-traditional, out-of-the-box solutions. We keep on, say, well, we've done this, but the system restricts us, and the Ministry of Finance doesn't allow this. And we need to find solutions and give them to the decision maker and say, well, please, this is the way to solve it, but I need your support here. But I think it's not just the family medicine program. One of the obstacles, this is one obstacle, and there are solutions that need working groups to solve them. But to provide good primary care services, family physician is the team leader, but it's not the team. We have a great problem in the quality of nurses and not having proper health educators. And these do a lot, and they can save time so the family physician can focus more on some of his clinical skills and have a supportive team that can really work. I've worked for long years in primary care, and I know that we really face problems with the quality of these people, especially in major cities with the Saudization. I support having Saudi staff, but we have problems that we need to look in deeply and work on solutions.
Thank you, Dr. Noha. That's really unfortunate. All over the world, they put incentives for medical graduates to join family medicine, while we have graduates who want to join these programs, but we cannot accommodate them.
And we have a new problem, is that we are losing the family physicians that have graduated because the situation in primary healthcare centers is not optimal. They get trained on skills, and then when they go to primary care centers, they cannot they cannot really professionally grow and utilize the skills they have learned. So they get rusty and they get sick of this. I want to do this, but this is not available. I want to do that, but I don't have access to the lab in the hospital. I don't have the lab that's supporting us does not have these things, and they feel intimidated by this. And I know several family physicians that have resignated, family medicine consultants, and they've resigned and went to the private sector. I'm not saying it's bad to get them in the private sector, but we have a great need. And the reason they went is not with the new salaries. I mean, many people are saying just for the salaries, by the way, but we want them to stay because they love the place and they love giving the service. We don't want to keep them there just because, well, I'm paid well here and no one else pays me as well. So, and that's not a good way to keep people. So I think we really need to improve, as Dr. Assam correctly mentioned, and you all mentioned, that the infrastructure, the system that gives me, the family physician practicing primary care, the facilities and the needs, the access to whatever I need to provide good service to these people.
Thank you. Dr. Tawfiq, you want to add something?
Yes. When the ex-minister of Saudi Arabia, His Excellency Mr. Ahmed Al-Khatib, appointed as a minister, I went to the group to congratulate him. And in the morning, we are around 200 people, all the leaders and the high officials at the Minister of Health. So they congratulate him. Then I raise my hand, Your Excellency, the Minister, I will not going to praise you or whatever. I want to tell you two serious issues you have in your life as a minister. His face changed 600 colors. He said, what, Khoja? I said, the primary health care. He was in front of Dr. Basima, was there. the primary health care, and the patient safety. And really, I would like to thank the organizer, the scientific committee of this forum, the Saudi American Healthcare Forum, that they address both of the issues. If we can bring a recommendation from this forum to the Shura, to the Minister of Planning, Minister of Health, Minister of Finance, that I think two issues as a top priority in the Kingdom of Saudi Arabia is the primary health care as a health of the nation, and second issue is patient safety and quality. The issue of training, when Dr. Hamad Al-Mani asked me with the team to evaluate the training center in the Kingdom of Saudi Arabia. At that time, we said that we need 2,000 training center for primary health care, because the need is 10,000 family physicians in the Kingdom of Saudi Arabia at that time. Now, Montagut came to Saudi Arabia just 2 weeks ago from Canada, I think from North America. He came and he said, no, the reality you need now 18,000 family doctors, not 10,000. So we need more training center. And if you see the training center for primary care in the Kingdom of Saudi Arabia, they are less than 40. So how come we can meet the challenge, this one thing. Other issue, I urge any people who are going to speak about the future of the primary care in the Kingdom of Saudi Arabia to be a public health oriented primary health care. I mean that it's not only a clinician led, a family physician led, it should be a multidisciplinary, multi-teams approach. This was realized by two GCC countries, Oman and Qatar. Oman, 1 month ago, they asked me about this issue. I said, this is right. So I spoke with the concerned people in the Imperial College London. So we are going to have, by the end of this year, workshops for 100 candidates who are a family physician in the primary care in Oman to be trained on the concept, the 8 dimensions of the public health, so they can address the whole society, not a disease-oriented. This one thing. The other thing that Qatar, they have a collaboration with Boston University. They have a very clear approach of the community involvement and the public health involvement in the primary health care. So we need to go to send our people. I know at the period, or at the era of Dr. Abdullah Rabia, His Excellency, the ex-minister, he sent 100 people to Johns Hopkins, but it's not enough. The Kingdom of Saudi Arabia is a continent, it is a qara, it is a huge country. So we need at least 1,000 public health, primary health care people to be trained in Johns Hopkins, in Imperial College London, in Faculty of Public Health, to be trained on the calibers and the qualities of public health within the primary health care. So this is an approach, I think, is not much given attention in, even we send, my son was one of them, he is in Johns Hopkins, but we need to have more and more. So if there is a real collaboration between Saudi Arabia and America in this regard, let us utilize the expertise of Johns Hopkins in improving the public health in the Kingdom of Saudi Arabia, the public health dimensions in the primary health care in the Kingdom of Saudi Arabia. Thank you so much.
Thank you, Dr. Tawfiq. Again, for you, Dr. Tawfiq. Universal health coverage is usually refers to a healthcare system which provides healthcare and financial protection to all citizens in any country. And the achievement of universal health coverage is becoming increasingly important in the development agenda on all countries, and it's a key priority issue for the World Health Organization and most of the health society. So how can you see that primary healthcare can contribute in achieving universal health coverage?
Thank you so much. I think this is a question which raised 4 years ago by WHO. Now there is, this started 5 years ago, the social determinants. Before that, the health performance indicators. In the last 3 years, they came with the concept of universal health coverage. And this universal health coverage has few fundamental principles. One of them is equity, accessibility, and others, okay? Saudi Arabia the present situation of primary health care, as I asked Dr. Ghamdi, he said, and Dr. Basiliman, he said almost 98%, more than 98%, they have accessibility to the primary health care. But is this accessibility is an equity that everyone has the right doctor, the right person, in the right time, in the right need? This is a question. Second, is this a quality or accessibility just to go to the center? Are these centers delivering the right job? As Dr. Assam said, we need to train and so on and so forth. So the universal health coverage from the accessibility is excellent, Saudi Arabia. But from the quality and responsiveness component, we need to revisit and to do an exercise. Regarding the universal coverage by family physician, there is a serious, as Dr. Ghamdi said, and our previous in-depth evaluation, a serious shortages in the Kingdom of Saudi for family physician and other members of the team. So I think there are indicators delivered by WHO 3 years ago, and we need to come to this to put this indicator in reality, and ask the Ministry of Health to respond to these indicators. Are we fulfilling all these indicators? And see where is the gaps. We conducted, me and Dr. Muhammad Sayyid, to the old GCC, and we found gaps. And these gaps, it is very clear that the role of the primary health care is not clear in the Kingdom of Saudi Arabia in the universal health coverage. Okay. Second, that the connection between the primary health care and the secondary care is not strong enough. Okay. The referral system has a problem in Saudi Arabia. So I am a diabetic. I have a good family physician in Al-Ulayya Health Center, but he referred me to the consultant in the hospital. Long queue, improper management at the hospital, no referral back from the hospital to the primary health care, no interaction, no shared care. So this is the whole concept of universal coverage in the Kingdom of Saudi Arabia. It should be again another exercise within the primary healthcare health sector reform. So the decision makers at the Ministry of Health, if they want to reshape the primary health care, they need to look to the indicators of the universal health coverage as a component within the health sector reform led by primary health care. Thank you so much.
Thank you, Dr. Tawfiq. Dr. Isam, very quickly, we are short of time, and we want to give the chance for our audience to have questions and comments also. As mentioned by Professor Tawfiq, we achieved high coverage of the people in the kingdom by primary healthcare services, and we need to concentrate more on the quality. You mentioned that we have a quality improvement program, and we need to know a bit more about this program and your efforts on accreditation of primary healthcare centers.
Thank you, Dr. Mohammed. Maybe I mentioned it before regarding accreditation. The direction the Ministry of Health that reviewers to have a national accreditation for the primary care centers. We started with 100 centers according to the SAHF standards of care, and fortunately, and when the mock exam actually, when enter the first 25 of them is passing from the mock exam, because we prepared them and we secure fund to have, if you have any problems with infrastructure, to suitable places. And we started with the governmental institutions that we have built recently to start with regarding accreditation. The accreditation, as you know, is infrastructure, process-wise, quality, and several domains. And the accreditation is a snapshot. And we know that it's a snapshot of care in one point of time. It doesn't mean a quality of care all the way. And the quality, as mentioned yesterday, is a journey, not a destination. So we developed with that the total quality management in order to sustain the accreditation that we reach. You reach this level, you have to maintain this level, because after 3 years, it might go down. So we maintain that we introduce now the total quality management program to sustain the quality of care in these accreditation centers, because in the planning phase, we're planning to expand after the 100 primary care centers. Another issue regarding the quality to provide proper planning, we are planning in the near future to have demographic health survey. That is with the institution of IHME, Institute of Health Metrics of Washington, D.C. Dr. Ali Migdad is here. And we are planning to have like a census, and every primary care centers all over the country will do the survey for the catchment area of the primary. As you know, that primary care centers having catchment area. And we are doing the pilot maybe the next few weeks. That we have to have pilot by the file system. And then after Hajj, inshallah, after approval of the minister, new minister, we'll start the campaign. It will take about 6 months to 8 months to complete the survey. And we have more than 3,000 units, 3,000 units will be disseminated from the primary care centers to cover the survey. This survey is in order to have the database. Actually, we long time ago, we don't know the data actually. We don't know what are the community we are serving. We don't know who's in the catchment area. We don't know what kind of age group that we are serving. We don't know who's at risk, who's diabetics, who's hypertensive in the catchment area. We expect that we have only 40 to 50% of the population of the catchment that they are who's visiting the primary care centers. The rest of the 50 or 60 or 40, we don't know that. We'll know it by this survey. They are either it's health insured in the hospitals or they have go out of pocket money. And as mentioned, Dr. Tawfiq, regarding universal health coverage, one of the pillars of universal health coverage is financial risk protection, which means that you don't overwhelm the people by financially to have health. Although the system is free of charge in the primary care center hospitals, but some people, they will go pay out of pocket money. So one of the idea of universal care to have financial risk protection, because it might affect the social determinant, poverty and other things regarding the poor people and the middle class of the health coverage. So we want to know this area, how much we have in each catchment area, in each primary care centers, in order to plan for the future, inshallah. Thank you.
Thank you, Dr. Isam. Actually, I think that we are short of time. I'll give just a final question for Dr. Noha and for our speakers. Briefly, how much do you think of our health expenditure should be directed to primary health care? Dr. Noha.
Well, not less than a quarter. So not less, probably more to start with. But not less if we really want to see changes. You deprive the sector, as it has been for the past decades, and this is what we get. We're getting poorer health outcomes. And we don't see those poorer health outcomes immediately. They take time, but unfortunately, we do. I'll just close with saying, quoting from Martin Luther King, I have a dream. I've had this dream for about 30 years since I was in medical school. I have a dream of people looking at primary health care and being proud of going to it. I have a dream of changing an image that a survey I conducted in 2010 in one of the middle to high class sectors in Jeddah, a door-to-door survey, and less than 27% of the people knew that there was a primary care center within their neighborhood. And less than those have ever visited it. And we can see that in the outcomes. So even when you do have a good primary care center, or fairly good, if you wish, people still don't get the services. So I have a dream, and I think this dream, working on the obstacles and changing the whole healthcare system, reforming primary care, reforming the healthcare system, this dream will be reached. Thank you.
Thank you, Dr. We have still 10 minutes to close our session.
Excuse
and
me.
Yeah. Assalamu alaikum.
Walaikum assalam.
Dr. Fatma Al-Abadi from King Faisal Specialist Hospital and a member in the organizing committee for the Saudi American Forum. I would like to thank everyone in the presentation and the audience for Dr. Salwa Al-Hazza and Dr. Saleh, Dr. Naha, Dr. Tawfiq, and Dr. Isam, Dr. Basalma. Actually, this is a critical issue for us as a health education specialist. Primary healthcare centers is the key component that have the relation between the community and between the healthcare system. From my observation, I found most of the programs in Ministry of Health is fragmented relationships. Everyone work individually, no relationship between the others. I visit one program for breast cancer screening in one of the primary care center. Nobody knows about the others. And this is something that makes me sorry how the people in one minister, they are not aware about each other and they are not collaborate with each other. But this is not my issue. That thanks Dr. Noha when she said, look to the health, not to the disease. This is the main issues of the primary care center. They are waiting for the people to get sick and to go there. I wish in future to see the difference. The primary care center should have a board and relationship with the people living in that area, and they are part of that center to promote the health and find all the concern and issues of the people around them. And every single person in that area should have a file and aware, and they have a good relationship, a trustable relationship, and go to visit them. Don't wait for them to get sick. That's one thing. I wish to see it in future. I wish that to invest more in health education, patient education. This is the key component that you have it, and it will make the difference if we invest in that people, because when we do it at King Faisal, in only one program, diabetes education, we save millions, maybe 22 millions per year, while we are only costing 300,000. So we are spending 1 riyal comparing to 20 riyals saving money. So it's a cost-effective program, and that cost, give it to the patient educator and health educator, and it will be, the community will have a lot of health promotion, health education. Let them be creative with many or millions of creative programs around, and you will see the difference.
Thank you, Doctor. Actually, I've been told by the organizer that we should close within 5 minutes, so I'm sorry for that, but I will take as many of you as I can. Dr. Walid.
Assalamu alaikum, everybody. My name is Walid Abu Bakr. I am currently an advisor to the Ministry of Health here in Saudi Arabia, and formerly with WHO. What I would like to do is just to share with you some of the international best lessons and practices. How, and those examples are evidence-based, because as you know, WHO is known for conducting studies and generating evidence about certain problems and priorities. And primary health care is an issue for WHO, and many people in WHO circles have this passion about WHO. The question is, all of you raised the same important issues about primary health care. You know, within WHO circles, they always asked, from Margaret Shane to advisors to consultants, why WHO message is not getting across to countries? Why countries are not listening? Since Al-Mata 78, the Health for All declaration, countries are not listening. I think the reason is, and again, what Dr. Tawfiq mentioned, now more than ever World Health Report and call for primary health care, and now the universal health coverage. But I think the issue is, some of you touched on this, Dr. Noha did, the image about primary health care is not good in many countries. And as I said, what I'm saying is not just my perspective, it's based on examples, evidence-based examples. Some studies have been conducted, and when they asked people, communities, why you bypass primary health care centers and you go directly straight to the hospital? They simply said, many of them, I cannot recall the percentage, but most of them said, because we don't have enough confidence that our needs and expectations in terms of quality of care, in terms of efficiency, in terms of effectiveness will be met. So the issue of the image about family physician or primary health care as a whole is a central issue. It's not enough to go to the Minister of Health, in my views, and persuade him to pay attention to primary health care. This will not change the image. The image will change only when there is a demand from the community, at the grassroots level, that people they understand the strategic necessity for primary health care, and they don't bypass or avoid primary health care centers and go to hospitals. And this also will change only when the Ministry of Health or other partners will develop strategy for communication, for education, for information, IEC, with massive campaign at the grassroots levels in the media about primary health care and the need for primary health care and utilization of primary health care. This is one issue. The second important issue, and I will finish, the issue of training. You know, the image, if you talk to some fellow physicians or clinicians or surgeons throughout the region, not only in Saudi Arabia, their perception about family physicians is not good. They think, some of them told me, when people are, when they fail in the surgical arena or in hospitals, they go to public health or to family physician. So this is also a problem. You cannot promote public health unless there is a consensus among both policymakers, health providers, and most importantly, at the grassroots levels or community level with people that primary health care is the answer, not only to my needs, but as Dr. Nuha said, when people go to primary health care, not when they are sick, when they are healthy, when they go for checkup, when they go for their routine, procedures, if they have chronic diseases or so. Thank you very much.
Thank you, Dr. Walid. Dr. Salwa, you have a comment? Please, briefly, if you have.
Yes, thank you. Thank you, Dr. Besleman. I'm now totally depressed after this session, although it has been the most informative session in this forum that I have attended diligently over the last 3 days. But honestly, I am totally depressed. I can say, I as a Saudi national, we are the gateway to MENA. We know that, whether it comes to energy, whether it comes to the commerce, and when it comes to health, we hear these experts saying Qatar and saying Oman. And here we are, the Kingdom of Saudi Arabia, where we have led the Gulf area and the Arab countries. And we sit here and listen to these simple, small country, with all my respect to them, of course, from that point. We have to find a drastic solution. If we don't move, people, everything you said, Dr. Nuha, was music to my ears. But please do not make it a dream. Make it a reality. It's you and Dr. Ghamdi and all these people here in the Ministry of Health. I wish I was, but I'm not. You guys have to be those people that have to go out there and fight and voice. Because if you tell me about the funds, it should not be a quarter. Every single hospital, specialized hospital, should not be part of the Ministry of Health. It should have its own general organization and report directly to the cabinet. What the Ministry of Health, with all my respect to it, and I wish I could delete it, should be a like anywhere else, a state of a department. We should, in the Ministry of Health, only concentrate on the primary health and leave every single other hospital for other people to care about it. So I'm sorry if I'm passionate about this. Dr. Khoja, thank you for what you said about me. I think there are many other people much better than I am from that point. I appreciate that. But I mean it. I hope to God that this forum will come out with exactly anything if we can do is to actually promote the primary health, because it is the essence. Each and every one of us, we live and die. We've never gone to any other ministries. May it be the Ministry of Commerce, but there is not one single person in this room that has not dealt with the Ministry of Health. From the minute we are born until we die, whether it's the vaccinations, whether it's labor, whether it's whatever you want to call it, because the Ministry of Health is the essence of all the ministries in the Kingdom of Saudi Arabia. Thank you.
Thank you, Dr. I'll take only one. I'm sorry, we have to close, but I'll take the last comment from Dr. Saleh Al-Ansari.
After this unfavorable history of primary care in our country, and under the high and increasing prevalence of NCDs, car accidents, smoking, backlog of cases has increased a lot. And I don't think we can look at healthcare as only primary care, secondary care, or tertiary care. Let me shed light on another level of healthcare, which is called primordial healthcare, which is known maybe by WHO terminology as basic health needs. And let us concentrate on health promotion, health education. Until we have an effective primary health care, we have to look at primordial health care, and let us concentrate on physical activity, nutrition, lifestyle, media, social media, school health. And this can be done at very, very little expenditure and at a very low cost. Probably we can do something to treat or to manage or to deal with this huge backlog of cases that has been accumulating over 20 or 30 years of poor primary health care. Thank you.
Thank you, Dr. Saleh. Actually, health systems all over the world are changing, and primordial health care and self-health care is becoming one of the main challenges and one of the main new directions of all healthcare systems. Before I close, if you have any response to Dr. Tawfiq or the other panelists.
Thank you, Dr. Basiliman. I don't know what to say, Dr. Salwa. It is, look, let us, we diagnose the problem, okay? But we need to take an action. I would like to ask from the audience, who is the one from Ministry of Finance here? No. Raise your hand. Who is the one who is from Ministry of Planning? Now, I am speaking about now. This is a very crucial component of healthcare system. Who is from the Wazarat al-Iqtisad? Okay. So, it is not only a Minister of Health, primary health care. It is, as you said, is a ministry's problems. Because of this, I raised the issue of public health. Public health is not a Minister of Health, it is a health of the nation. So, I wish the people who are responsible, Dr. Fatima Al-Abbadi and your colleague, that this forum should come out with a strong recommendation. It is not a gathering and ventilation, evaporation of ideas, and then that is it. No, it should be a real working paper coming from this conference. The third issue I would like to say, if we can come out with a concept putting people first, not patient, people. Why? Since I know myself as a family physician, I have three principles. Keep the people who are healthy. They are 60% of the community. Keep the people who are sick, 20%. Manage them properly. Primary health care, secondary care, shared care. People who have complication, diabetic retinopathy, renal failure, CVA, whatever, myocardial infarction, all of this, cope with the disease. So this is the concept of people putting people first. And I urge you, my dear colleague, to read this book. And I'll send it to you, Dr. Salwa. And please, in your committee at the council, ask them to revisit, especially you have Dr. Adnan Al-Bar, He revised this one with us. This is the book that came by WHO, Primary Healthcare More Than Ever. And here in page 41, they want the system like this. It should be primary care brings promotion, prevention, cure, and care together in a safe, effective, and socially productive way to interface with the population and the health system. So it is not a health system away with the population. In short, what needs to be done to achieve this is to put people first, to give balanced consideration to health and well-being, as well as the values and capacities of the population and healthcare worker. We should start to describe the health of the patient, the health of the nation, with effective, safe, essential component of primary health care. Are we going to go together in this direction? Is a big question. Thank you so much, Dr. Baslima, and your colleagues.
Thank you, Dr. Tawfiq. As you can see that we have, it's clear that we are facing a lot of challenges and difficulties, but I'm sure also that we will success and the future is for primary health care, inshallah. Thank you for your listening and for your contribution, and thank you for our eminent speakers. Thank you very much.
So we're going to do the awards now, and then we'll take a 5-minute break just because we're running late, and we'll then proceed with the next panel, which will be our last one before lunch and the close of the forum. So at this point, I'd like to honor Dr. Baslima. Thank you very much. You were wonderful. Next, we'd like to honor Dr. Koja and thank him very much for his contribution. That doesn't count as our group shot either. So next, I'd like to honor Dr. Al-Gamde, please. And of course, Dr. Noah, please come forward. Challenges of managing health information, and it will be moderated by Dr. Al-Hami, please.
الحمد لله رب العالمين والصلاة والسلام على خير المرسلين نبينا محمد عليه وعلى آله وصحبه أجمعين. Good afternoon, ladies and gentlemen, and I would like to welcome you for this panel discussion. And I'm really delighted to be the moderator and be participating with distinguished speakers. I would like to welcome all our speakers. Actually, I have done a lot of paraphrasing, shortcutting for their biography because, mashallah, their biography is too long. The topic that we're going to cover in this session is a very interesting one. It's about the challenges facing the management of health information. As all of you know, the journey of the e-transformation that happens in healthcare started by the automation of the business processes, taking the medical business processes from the manual to the automated, and that's by the introduction of new medical systems. At that time, the data was captured in paperwork, and people at that time, they don't know the amount of the data they are collecting, they just know the amount of papers they are collecting. With the transformation that we had to the use of the electronic health records and other systems, the data has been moved from the manual to a digital form. At that time, each department was looking to the automation and independent from other departments within the healthcare provider. So we end up having an island of systems within healthcare providers that created problems. Afterwards, there was a demand to let these systems talk to each other. So there is the integration initiatives, projects to link these systems together. By linking these systems together, we found out that there is a lot of data that we have within healthcare providers. This data, and we are just measuring the data that comes from the system. Still, we have unstructured data that we didn't capture by these systems. If you look even to the practice that we have within medical or medicine, people or practitioners are moving from the ad hoc subjective decisions to evidence-based. In order for them to make the decision by creating evidence, they need to convert this collected data to a form of information so they can use it for making their decisions. A lot of CIOs and maybe people working in knowledge management were being asked by management and by physicians, we need to have reports, we need to have KPIs, we need to have our descriptive analytics, and we are looking for our predictive analytics. Can we do that one? Now, if you look to the data as the startup for this journey, we need to think about it in terms of what is needed. So I would like to ask Dr. Krishnan about, to start this project, we need to pay attention to the data. And having the right data, that will lead to create the right information. How about the state of the data? How we can really assess the data, how we can do the control for the data in order to come up with this accurate data in order to put it in production for information.
Yeah, thank you. So data quality is clearly very important. Even when computers still had big floppy disk drives, we said garbage in, garbage out. So when you look at healthcare data, similar to any other data set, the data quality is extremely important. So one of the things, there's two dimensions of data quality to think about. One is the completeness of the data. So if you're looking for a minimal data set, how many of those data elements are missing? And that's the traditional way of thinking about it. The other way of thinking about data quality is consistency with a specific definition. So when we ask for a data element, we ask for a blood pressure, let's say. It's very important to be very specific and almost create micro specifications as to what that means. Because when I say blood pressure and I look in your electronic medical record, or if I say blood pressure and I look in someone else's electronic medical record, the data definition may be different. And so data quality is really a combination, in our opinion, of those two things, the consistency of the collection, as well as the specificity of the definition in order to get what you want.
So, Dr. Nick, what do you think about, is it difficult to enforce or build the culture within the healthcare provider to ensure that this data that will be entered by the physician, nurses, it's going to come with high accuracy and completeness?
So I think there's an implication that the clinical community captures accurate data. I don't know that that's necessarily true always, and as Dr. Krishnan said, the standards may be different, and reconciling different people's perspective of those data elements. But inherently we think it's going to be accurate, it should be, we have reference values and so forth. I would sort of turn that question around a little bit and ask, what's the purpose of collecting the data? In many instances, we're sort of, we want to collect the data, we want blood pressure, and we think there's some intuitive reason to do so. But I would always bring it back to a slightly different perspective and suggest, if you're collecting it, what are you going to do with it? Ultimately, we have to have some purpose for that data. And whether it comes from the clinical professionals, although increasingly I think we're using data that comes from our patients and from other sources as valuable, and it has even more problems of conflict in terms of the reference and the standards and the sharing of that data. But if we see value in that process, I think that will drive part of that reconciliation and the cleaning up, if you want, of that data. But it has to come with a purpose. So there's no point in collecting blood pressure if you're not going to do anything with it. So driving that whole process in a way that allows us to achieve some positive outcome in health or healthcare is really, for me, the main sort of driving aspect to the collection of that information.
I see. So, can I ask Dr. Swalem, King Faisal Specialist Hospital has undergone a very successful story for building a data warehouse and analytics. How was the approach that King Faisal Specialist Hospital done with determining the data needed for building such analytic system?
Thank you. Bismillah ar-Rahman ar-Rahim. As you said, Dr. Bender, the journey of King Faisal Hospital started 10 years ago, almost. We're completing a decade and building our data warehouse. And it's a journey, and we are going through cycles of waves of enhancement and changes and improvements. Initially, as Nick have mentioned, that we should put ends in our envision our landscape, so we can go downward where we wanted to be, what are the metrics we wanted to measure, what are the objectives we wanted to reach, so we can go downward and see whether we are having the right systems, the right process, the right data, the right definition. I must say that the beginning was difficult. It was a new idea, new concept. The management in general were used to simple reporting, just a y-axis and x-axis, simple report in Excel sheet, rather than the cubes, the dice and slice capability of data warehousing with the complex key performance indicators. So the beginning wasn't easy, and we had to define, based on business standards, what are the basic metrics for hospital operation, and we put standards to follow for the definition and for the benchmarking. And then we went through a long technical journey to have the right primary systems, right data, fill the gaps. These systems were built for medical operation, not for producing management reporting, which is a big difference. And we had to go through a journey of filling the process gaps, data gaps, and definition issue, which is still a big issue because it can change the whole picture of the outcome if you don't put the right definition. So bid, for example, we figure out in the beginning of that journey that length of stay had 7 different definitions. When we put everybody together, 7 different definitions for length of stay, which is a vital basic statistics. So we had to put a governance body, the executive and steering committee, administrative committee, and project team to go for day-to-day work, setting what are the objectives, even with things that we don't know about, we just put the best standard, quote unquote, although they don't like the statement. And then we build both the technical capability and the analytics capability. So the manpower who can understand what does cubes mean, what is the impact of data. And then, as Nick said, when people see the value, then will be, I remember physicians saying, we are admitting this patient, it has to come out from the system properly under my name, because now the value of it is visible and it has a big impact. So it was a difficult journey, and we are going through cycles of enhancements. And it's, so far, I consider it successful with all the difficulties we went through.
Dr. Tuwajri, I think you will agree with me that we've been hearing the phrase that the data is an enterprise asset. In a lot of executive meetings, they keep repeating this. But do you think the organization are really looking at the data as enterprise assets?
Thank you, Dr. Bender. I think this is now, we see a trend of this worldwide. Hospitals are really looking into data as major assets of their organizations. I think simply if we again, as Nick said, we have to look back and say why we are doing this. What's really the key values and the objective of doing this. And if we look at simple statistics that is done by Kaiser Permanente, if you are aware of the pyramids where it says 20% of the population consumes up to 60% of the money spent on healthcare, that can only suggest that we should really rely on data and good data to manage wisely, because this is really the segment that is really the highest potential of saving and the highest potential of care that we should be targeting. And for that, I think data becomes an asset, and that was really one of the reasons data becomes such an issue. Big data became a trend. Predictive analytics has been now tried in various health organizations in the world. And the initial science showing really some good savings and good numbers. Again, we should not wait for the data to be clean so that we can, get the benefits. I think it's a journey. Once you start, you see deficiencies in the data, you clean the data, you see value, and then you keep continuing that until it becomes, but the end result is how I can really do more with less or with the same. I think that's the key value. And healthcare is such an area and service that really keeps increasing on terms of budget. I mean, if you look at all the countries, there's no single country that has decreased the funding of healthcare. Healthcare has been always increasing, and countries around the world is really trying to figure out the best ways to at least keep that increase in a manageable way.
Yes. Dr. Krishnan, since the source for creating the information is the data, and the data is really a valuable asset, as Dr. Tuwaijiri and Dr. Suhaila mentioned, what we need to do in order to govern this data to ensure that everyone will stick to the policy, that the data that will be entered by anyone will be accountable for it, ensure the accuracy, completeness. Do we need to have like a change in the organizational structure and make someone responsible for the data, or is going to be left, for example, to the traditional IT department to look after it?
Yeah, I think the last speaker actually mentioned this. I think that traditionally information technology included the information as well as the technology. In reality, many organizations have now adopted the role of the chief data officer, whose job is to think through the data from start to finish, how it's entered, how it's standardized, how it's used, and there's a data governance committee that's usually set up, which is a multifunctional committee. Even the large US payer, Medicare, has a chief data officer who's accountable for that. And it's critically important. One, it sends a very strong message that data that's being entered needs to be entered with a high degree of accuracy and fidelity because of its use. Two, the standardization of definitions is very key. Even the question that was raised around length of stay, we all operate with the thought that those simple definitions have a consistent definition, and they do not. Three, even some of the ideas of who can change the data or update the data is a question for the Data Governance Committee and who can access the data. And lastly, from a privacy and appropriate use perspective, that's another component that's really important as well. Whether or not we have now the ability to do role-based data access, so the Chief Data Officer thinks about that as well. It's dangerous sometimes if everyone has access to all the data, especially from a privacy perspective, but it's important that the right people have access to the right data at the right time. So I think the role of the information technology department has become more of the technology and the piping, if you will, to let the data flow. But the role of thinking about the strategic value and the data quality really should be a separate position, that of the Chief Data Officer.
Dr. Nick, you just mentioned that we need to know what we want to collect in terms of data gathering. The problem that most of the end user will come and ask for the final outcomes. I need certain KPIs, but he didn't come and explain to you the data that makes or build that KPIs. How do you think the approach that we should do with the business users in order to define these data needed for this information or certain KPIs?
So I think my two colleagues actually demonstrated one of the great ways of achieving that. So Dr. Osama talked about the journey specifically and the fact that they didn't know. And whilst I'm always looking for the reasons for capturing that data, quite often we don't know what we can do with that data initially. We know we have to capture it. You can't improve things if you can't measure it, but we don't always know what the data elements are. And I just love the concept that both of them described that said, we're going to start this journey and capture something and then you refine it. It's a constantly refining process. And in fact, in the conversation that we had before we got on the stage, we heard from Dr. Krishnan that you'd been collecting data for a year and only to discover that it was valueless because there wasn't a reconciliation of the standards. But that wasn't a bad thing to do ultimately because you learned from it. You were able to refine that message. So my sense is that we know that it's good to capture data. We should get on and do that and then go through the constantly refining process that says, let's adjust the course. We have a good sense of value. And the best analogy I can give around this is the telephone. When the telephone was invented many years ago, the response from the general public was, who on earth would want to talk to somebody that's 10 miles away or 50 miles away? And now, of course, we have so many variations of how to use that technology. And I think the same is true with data. As we learn more and we capture more, we're starting to really understand the value and how we can apply it. So I think it's important to have purpose, but at the same time not use that purpose to limit or confine your data capture process and use it as a journey to find those goals, because they may not be clear. I think we're going to capture something in 5 years' time that we wouldn't have even thought of.
Dr. Swelem, I think now you just said that the project that you've done for the analytics, it's going to do another iterations for maybe adding data. If you look to the information, or let's say the generic concept that more data, that's good for me. Right now you have collecting the data from the medical systems. And I believe the research center might said we have the genome data that we can also couple with the data that we have and can provide some extra information for the physicians for making decisions or for some medical cases. What are the challenges that you are seeing from increasing the number of the data, getting it from the research, or even getting some public health data to be integrated within your system? Is it going to be something you see it from management perspective and easy, or it will be hindered by several or many challenges?
I think there are a number of challenges, although I like our CEO statement, if there is will, there are ways, not just a way. But these are the things that needs to be considered. Definition is a major issue, Agreeing on standard to be followed as a definition is not easy, especially if you are going outside the four walls of the hospitals. And for research purposes, the analysis, the needs for research might be different even for the clinical operation, for the management needs. So we have to be careful addressing the definition. There's also the technical challenges, which usually it's the less challenges compared to the other. Who's going to own the data? Where are you going to reside the data? Is it just fetching, or are you going to store this information, the confidentiality component? The new threat now, everybody's talking about the cyber crimes and the risk of these data, attacking these databases. The most important thing is the governance. Who's owning? Who's making decision? How do we make decision, or how to make decision? I see these are the difficult part. I think there should be a national initiative to address the public, across the board, the public data. There is a huge treasure and huge chances for improvement if we just make that concept. I know that the registries, we used to have the disease registry and the King Faisal Research Center, and now it's moved to the National Health Center, which is a great idea. So all the pediatric genetics diseases, all the cancer registry, not just in King Faisal or in the, although we used to host the cancer registry in the hospital and the kingdom and then the GCC countries. But putting it in a central place is essential. Even moving these capabilities has to have its own personal capability, people who can really manage this data. It's not just getting the smartest company on earth to bring you the databases and store all that, but then what would you do with it? The famous example is the Dr. Khalid Al-Rubayyan with his diabetes database he has a marvelous, beautiful collection of data from different hospitals, and he's showing you which hospital is better than the other, just in an anonymous way, because it's very sensitive. There's a lot of value you can generate out of this, yet we are not making the value of it in an environment that makes data can make the difference between life and death.
Dr. Tuwaijri, I know that when you've been working with National Guard as CIO, there was a data warehouse project that been built over there. From technical perspective, people think that building a data warehouse is just a simple database schema, that's it. It's actually, it's more than just building a database. Can you just shed the light on the technical challenges for building any type of data warehouse?
Thank you very much. I can't really suggest that project was a successful project, so I'm not really suggesting that people here would take it as a good reference. And I take blame for it because at that time, that project was driven by technology. So it's really was the companies who providing analytics tools who were trying to push their technologies without really adjusting the business need for it. So there was a big disconnect between what the technology can provide and what the business needs are. And that project did not really materialize in the best way. I think if someone has to start fresh now, I think tools are better now. I think experiences are there. There are some good hospitals, and not necessarily in the US. So we're not always suggesting the US hospitals to be the best when it comes to analytics and it comes to smart, because Europe is under tremendous financial pressure. And in the past 3-4 years, they've been doing things much smarter than the rest of the world because of the financial crunch. And these present some good, really, some good lessons learned for the rest of the world. I see also, and this is a trend coming, I see that is involving the patient is coming soon. Please remember that we are talking about a new generation who's technology natives, people who are now using their internet smartphones when they are 10 years old. And when they become 30 years old, they would never accept the kind of data provided to them that currently provided. So there is this gap that people has to really be aware of and getting the patient, involving the patient, and incentivizing the patients for providing the data. Not just, I think there was some sort of behavior we've been doing in healthcare. We've been always thinking on behalf of the patient. We as doctors think that this is best for the patient and we decide to do it. But we never check with patients what they need. We need to check with what a diabetic patient would like to have in terms of data. I am collecting a lot of data for this patient. So in return, what this patient can benefit from all this data being really collected and acquired. This data has to return back maybe in a form of patient education materials, in form of maybe chat forums between patients who suffer from the same disease and make a better healthy communities. So there is a lot when it comes to data, and I think the missing component today is patient, but I see it coming soon. There is a study conducted by Accenture and it was published in the government summit in UAE, 80% of the UAE population expects more mobile applications and more data on their mobiles from the government. And I think healthcare in this region is still considered as government services. Thank you.
Thank you, Doctor. I would like to open the ground if we have any, or the floor if you have any questions.
Thank you all for this informative discussion. My name is Bedr Hablani. I'm from King Faisal Specialist Hospital Research Center. I have two questions. One is related to disease registries and electronic health record. Are there good examples of opening up the EHR, possibly through the data warehouse for search purposes in general, or more specifically in support of disease registries? That's my first question.
I can take that one. Yeah, there are some good examples for kidney disease, patients on dialysis, for example. The NIH, the National Institutes of Health in the US, has funded a renal-specific disease registry, which for the longest time has utilized claims data to describe the population, both for patients on and prior to dialysis. That's the US Renal Data Service, usrds.org. That data serves two purposes. One is for general public use, so you can go and see a lot of descriptive information. And two, they make standardized analytic files available for researchers. There are now movements to try to do the electronic data submission through electronic medical records as well. Interestingly, the administrative claims data has a tighter data definition because the claims are very well defined. Electronic health records are much more variable in their underlying data definitions, and so despite our attempts to use some of those data and transmit some of those data, it's been challenging because the data definitions are so variable. The example I shared earlier that was referenced was one of those issues where a test was a test, but without the micro specifications of was it this variant of the test, that variant of the test, or the third variant of the test, the data was poor, and so if one did research and one assumed that data was consistent, one would be mistaken. So I've seen disease registries more successful either in claims-based registries for electronic data submissions or, unfortunately, through web-based data submission or paper-based submission.
So I want to add another couple of examples that I think are important. One locally, and my colleagues maybe can comment on this, where the definitions aren't necessarily in place or as accurate, but for MERS and the emergence of that in the kingdom and the challenge of tracking all of that, I have to believe was a significant value add to be able to see where that was occurring, whether you were in control or whether there was an outbreak. And in the US, we've had a significant problem with vaccinations and the measles outbreak that was essentially down to tracking of an outbreak that occurred in Los Angeles, and then there was a couple of additional outbreaks that were linked to all of that. And the ability to follow all of that, even though it wasn't a regimented, so the CDC does track all of that, but not in the same level of detail. And in some instances, it was as simple as just following the data and following where people were reporting on this that allowed us to actually try and manage and hold back those disease outbreaks that I think is very, very significant and extremely important. It must have been here in Saudi Arabia as well.
Bender, if you allow me. Yeah, just I look for the future when it comes to registries. I think if we, it's not only my thinking, but the future should carry a very strong computing capability within different organizations where registry is not needed anymore. Registries are not needed anymore. You want a disease information, you can just send a query, you get the information with a strong analytical capability of different systems, but this might be in the future. But for now, we are taking the data, we are massaging the data, we are producing maybe a different picture of the original concept of that data. And I think we should build the capability of the so robotics to the extent that then this registry became more of querying the primary systems across the hospitals involved or the country to get the right information at the right time. We have a very simple example in linking 5 hospitals in Riyadh for getting basic information in the emergency room. The question was, if the patient is comatose, I need to get information from 5 hospitals. One of them is the National Guard, King Faisal, Security Force, King Khalid University, and King Fahd Medical City, and Security Force Hospital. So it's successful, although it's basic data sets that can make difference for treating physician. The concept should be expanded so that you can cross the boundary of these what's called registries to get the right information, rather than this is the cliff lip, these are the information, you are limited to these the data sets.
Okay, my second question is, some countries have specialized systems to track public health indicators and identify emerging epidemics. But could such data be extracted directly from the patient medical electronic health records? If not possible, for real-time tracking, can the data be at least considered reliable for epidemiological research?
So I think great question in terms of the accessing of that data, and in many instances we have structured information. What we've done typically is ask physicians and clinical professionals to be data entry clerks. They're not very good at that. And as physicians, we typically are not interested in discrete data values. We're interested in the story behind the values. And that creates a conflict for the capturing of that information. One of the great opportunities, I think, that exists is natural language processing. I know Dr. Osama is a keen advocate of that. I think the technology has progressed significantly to allow us to take that unstructured information, create tagged, structured data in some instances, and there's even a thought, instead of structuring it, do we ever need to structure it along the lines that you talked about of creating a database that you just access and ask questions and you don't really structure it ever? And that's really the concept behind IBM's Watson tool set that they're applying to cancer specifically, but I think they'll expand it. So my view is that the answer to that is absolutely yes. There's a question of accuracy. I would suggest that natural language processing has approached somewhere of the order of 85–90% accuracy, which is good enough for reporting, maybe not good enough for clinically actionable elements that you use for treating a single individual patient without reconciling and making sure that it's accurate. And it's actually higher than that depending on the elements that you're pulling out. If you pull out pharmacy information, you can do that very accurately, almost at 100%. Social smoking habits and so forth, much harder to do. But you know, depending on the specific data elements, I think very accurate and absolutely plausible, and I think an exciting opportunity to apply all of that knowledge and analysis to this unstructured information that we have today.
If I may, I would like to share two experiences. One in Singapore, which is similar to Australia, where they have actually a health information exchange across a national level. So this is specifically, Singapore is now being seen as really a role model for connecting all the healthcare setting, including pharmacy, including primary care and tertiary care, into one, and then building analytics on top where we can be useful for using predictive modeling, then can be used for population health. The other experience I would like to suggest is the Basque region in Spain. They have done a project which is again addressing this 2060. So there is the 20% of population consuming 60% of our health budget. And those are usually people with elderly people with multiple chronic disease management. So they did actually a specific program where they have extended home health care and used serious gaming technology like the Xbox where they engaged these elderly people to manage their healthcare on a daily manner. And that project has been seen now by the rest of the world. In fact, the project manager is now an advisor in the Obamacare. So this is the tool that I would suggest for you to look at.
Any further question? Yes, please.
Assalamu alaikum. Thank you all for this excellent discussion. I'm Dr. Jawahar Al-Fassam, emergency medicine physician. Just a comment, we're talking about health informatics, smartphones. I just have two comments. One is not everybody can possess or have smartphones. There are some people who cannot afford it. The other is we use it for communication with patients for their appointment. Some patients come and they said we don't have the phone, so they want the formal, the paper appointment thing. The other comment is as an internet, or it can be hacked, it can be slowed down. So we face the problem of the system is down, and it slows our work. So is there a backup or for this? So these are the two comments I'd like to raise. Thank you.
So I think great point. That's absolutely true that mobile devices are not completely prevalent. But I would point you to some of the other countries. So Africa is one that I'm very passionate about. I was born in Africa. I track it very closely. Same problem. They don't have smartphones, but in fact they've done something really interesting, and they're using text messaging in its most basic form. There are more mobile telephones than there are public toilets in the world, and they're using it for absolutely amazing positive health benefits for tracking. I'll give you a couple of examples. One was a system for reviewing patients or mothers to be to assess them for their pregnancy risk using mobile phone technology to communicate that, so that they could determine whether that mother needed to come the 8-hour or 12-hour journey to the clinic to have the baby, or was it safe to have that baby in the local area because she was a much lower risk. They've done it very effectively, shown huge amounts. So I agree with you, but I think we don't have to all have an iPhone or a Samsung Galaxy to be able to achieve some of the effects of that technology. And the gathering of that data, simple data elements, revolutionize the safety of birth or childbirth in a couple of African countries. But great points, thank you.
There is a strong penetration of mobile. I don't recall the exact figure, but I think it's 1 to 2. For every national, there is 2 mobiles in Saudi, which is more than the ratio in US. It's 75% of our population is below 15, so we are a young generation who is very oriented, as Dr. Twajri mentioned, to technology. So there is widespread of mobile. When we wanted to introduce patient portal recently, and King Faisal, the CEO, said, what if somebody doesn't have a mobile? What if they don't have the cost of the internet, 3G or 4G connectivity cost? So this is considered part of the challenges. But for the continuity of system, it's not just for the mobile, it's for the healthcare in general. There is zero tolerance for having system down now. Zero tolerance, because it's not anymore a luxury system. It's controlling every corner of a healthcare organization. And I tell you, in King Faisal, when the system goes slow, and Dr. Russell was here, can tell you, patients are sent home. Simply, the physician cannot see lab result, can't see radiology report, can't see the appointment, can't see what's... we go into almost stone age to us, when people are still using paper. So when it's a big commitment to move into this big domain of electronic system. So we are having a lot of architecture to maintain the active and live systems. And this should be the trend across the board, because it's, as I said, we have examples where data make big difference in surviving patient, and the opposite.
I think 2014 was an important year when it comes to mobile technology, because it's the year where mobile technology has passed the normal computing technologies. So for the first time, people now accessing internet using mobile is more than and the curve is so sharp up. And if we follow the trend, it makes a lot of sense that concentrating on mobile technology is the way forward. I think even companies, major, huge companies like Accenture, there is now a huge division called digital, which is really just to address this new trends that is coming, and this is also happening for the rest of the company. And I think the end user and organizations will follow that. I think we follow actually the trend of people now. If you look at, I look at my kid at home and I'm watching the match on the TV, he's watching the match on his mobile, because he's not just watching the match, but he's adding comments and he's blogging and he's doing so many things where you cannot do it in the normal technology.
Salwa Al-Hazza, King Faisal Specialist Hospital. I just want to commend what Dr. Suwailim said about the King Faisal Specialist Hospital being first initiated the first cancer registry. Today someone was presenting a slide and it was so interesting. She mentioned on her slide, it said Kingdom of Saudi Arabia, but in reality she was giving the statistics of the King Faisal Specialist Hospital. So I think now that KSA has actually taken over, I think it's very healthy, although in reality, and Dr. Suwailim knows, that the King Faisal Specialist Hospital is the biggest partner, especially when it comes to the cancer and to the genome project. But I think if we start thinking not just of our own hospital or our own territory, but think of the Kingdom of Saudi Arabia as many hospitals, and if there's one center which KSA has done, I think this is going to be very informative. I think this is very important, especially now since we're coming into the e-health. Another important thing, and maybe I'll impose this on Usama and sort of jerk him a little, is when will the day come, when the smart card, where you can actually carry your own information within your own pocket. This is something very important, not only for cancer and for hereditary diseases, but for many things. And I think hopefully this will not be a long ways down. Thank you.
Thank you, Doctora. We don't disclose all the information, but we just completed a part of the patient portal, the blue button. Blue button is a concept that was initiated by VA in US and then adopted by, I think, Medicare, Medicaid. It's basically you have all of your information portable. You can take it from anywhere, you can download it. It's built even in a structured format. So when you have a system that supports the blue button, the information will go to different location of that system. So the allergy will be stored in the allergy, diagnosis will go to the diagnosis, and it's just give us a couple of weeks, it's there. So you can download all of your chart anywhere you go. And we are not reinventing the wheel, it's a standard in US, and we are among the early adopting it.
Any further question?
Assalamu alaikum. Randa Baraja, Electronic Health Education, King Faisal Specialist Hospital. I have a question about just to elaborate about the database. I saw in America they have private sectors and non-governmental sectors. They provide a database that can be used for the public health programs. Do you think we can have this database as free for people to use it for their public health programs?
So you're saying that there is some public available databases there and it's being used by the regular users, ordinary users?
Yes, it's available for free.
As data?
As data.
Yeah. So you're saying whether this data will be available, or we're going to create something similar to them to be available here?
Exactly. Can we provide a database that can be available for anybody to use for the public health programs.
Okay.
They can based on their programs.
So I'm not sure I understand exactly what you're asking, but let me see if I'm on the right track. Is your question around the willingness or the ability to share all of that data with patients essentially and everybody to be able to access it? So I as a patient, not as a physician or an institution, would then be able to use it. Is that what you're asking?
Yes, it can be used for the social and the healthcare provider.
Right. So maybe I'm a little bit controversial in saying this, but I would say fundamentally the data belongs to the patient. I think the patient owns it. They have every right to it, should absolutely be able to use it. And Leonard Kish said 3 or 4 years ago, he described patient engagement as the blockbuster drug of the century. If you measured a drug and patient engagement was that drug, the effect that it has in positive outcomes is so extraordinarily strong and positive that we should all be doing it. And what you're describing, and I think is a huge opportunity, and I just want to shout out to the King Faisal specialists, the fact that they're doing the blue button, huge nod to you, because whilst that's a VA initiative, we're struggling to get that pushed out and making that data available. The fact that you're doing that is a huge opportunity for Saudi Arabia, the kingdom, and the ability of sharing and engaging with the patients so that they can use it. My counsel, my sort of general view is you have this wonderful opportunity to really bring the patients into that story, allow them to access it, and they can start to analyze their own data. There is nobody more invested in the successful outcome and the successful use of that data than the patient, even more so than physicians. And if you give it to them, you'll be amazed at what they come up with.
I think the other component of that is that the patient is really the only common variable in the system, right? If you think about it, we consider data from the perspective of who generates the data, a hospital, an outpatient facility, a pharmacy. But the commonality that links all those together is the patient. So to your point, I see a future where all the data comes together, just like today you have your banking data on your cell phone, and we have applications that run on that. There was an article in the New York Times maybe 2 weeks ago that described a patient who gathered all of his data, and he himself diagnosed he was having a brain tumor because he had all of the data and he went to confirm it with his doctor. That's the power of centralizing the data amongst the most common factor, which is the patient.
I have one more question. It's about the, maybe for Dr. Tuwaijri and Dr. Suwailem, about our invest in the electronic health education and most of the health system. Many healthcare providers think that these systems are really great for gathering data, for having the information on time, but at the same time they think that it's giving less care and time with their patient. How can you convince these healthcare provider about the importance to increase the use of these systems, especially in the downtime for this system or at the crash of the system at any time? Thank you.
This is a very important question, and I think this is really poses one of the big challenges that many organizations faces across the world is really physicians' resistance to using new EMRs and new systems. And I think that the best way to do that or to address, mitigate that risk is by involving physicians early on the process of acquiring and designing that system and building incentives so that for the physician, when the physician opens the record of the patient, he has information summarized in a nice, neat way that will really save the physician the time from going from one page to another on a paper base. I think just by demonstrating some incentives and values to doctors, they will buy into that. And we see two trends. There is the young doctors who are already bought into the idea. There are the older doctors who are still challenging. And this is, we see that the trend is becoming less and less of a challenge, especially with many doctors coming from abroad, from the US, using these EMRs. I have seen some doctors in one of my visits in the US is not only using one EMR, he uses one EMR in one hospital and a different EMR in another hospital, and was able to actually address both EMRs. So this is coming. In fact, when I was at the National Guard as a CIO, most of the young people coming back from the US are the people asking for more. Where is the EMR? How come this EMR does not address this or that? And I think this issue will become less and less in the future to come.
Can I just add to that? Because I think I passionately believe that that's a user interface problem. Physicians love the EMR, but they don't want to face the technology, but they've been forced to face it. Absolutely. And enter data, and that's not what they're good at. And it should, you have to be aggressive in your approach and your acceptance of systems. And to your point, the physicians, the clinicians, not just doctors, but everybody that's involved should be absolutely adamant that the process for getting information in shouldn't detract from the face-to-face time, which is what patients come into the hospital for. I don't come in to see you, the physician, looking at a piece of technology. I come in for this eye-to-eye contact and the interaction. And if the user interface and the EMR, which is a good thing, I think we all agree, and the data is important, if you are not delivering a system that allows you to focus on the patient, then the system is at fault, and that's what should be fixed. It's not about changing the process. We have to focus on the user interface and make it work for the physician and the patient.
We have room for last question.
Thank you. Thank you for all the speakers. I'm Samuel Ashkar from King Faisal Hospital. Actually, back to the previous session of Dr. Noha when she was talking about dreams. And to be realistic, in 2000, I think in Institute of Medicine, the recommendation was to be paperless at the end of the decade, and that was in 2000. So at 2010, the dream was in the state to make a paperless system, and I don't think it's achieved up to now. My question about the dream in Saudi Arabia, when we can think about EMR, or electronic medical record, to be among the whole hospitals in the kingdom. So when we can see really that the patient, when he visited any hospital in the kingdom, his medical record will be read by other physicians or emergency departments especially. So there is a roadmap for that, when we can see that as a fact, not a dream. Thank you very much.
That's a good question.
I think we're talking about the big brother, which is Ministry of Health. They are the one who are having the majority of hospitals. Maybe King Faisal, National Guard, Security Force, they are on a faster pace. But I know that the Ministry of Health are having a very innovative or smart strategy for adopting electronic health record, which is a big concept. And they have a big budget for it. I think the turbulence of changing ministers is participating to this, but I think they have strategy. Recently, the right people are involved, starting from Dr. Limni, Dr. Wahabi now, and the team they are having. I think we have all the capability of doing it, especially at this time. When I think the minister, the different sectors are moving faster, but the question is Ministry of Health that constitute, they have what, 250 hospitals or so. I think they have the strategy, they just need to go on with it.
And I would like to add, I'm always optimistic. I've been involved in Saudi e-health initiative since 2002 when I was chairing that, and I was part of Saudi Specialty Health Council, also supporting them. I'm very optimistic now after the new changes, the new Minister of Health. This really shows how important healthcare is for the government and for our king to have somebody who was running the oil and gas, the big Aramco CIO, CEO, to be in charge of the big healthcare agenda for Saudi Arabia, that's really a big step forward. And I'm very optimistic there. I think Aramco leadership with the knowledge and skills and leadership that the new minister will bring to the table definitely will, move things much faster than used to happen. There is really good talents at the Ministry of Health. I think with the right leadership, with the right pace, we will be able to excel. And to tell you the truth, we are behind, but we are not much behind the rest of the world. As part of my job, I'm leading Accenture for Middle East, North Africa, and I'm exposed to all healthcare around the world. I think there is a huge chance for Saudi Arabia to leapfrog and be ahead of the rest of the world, because we have the leadership. I think there is now a royal decree to move healthcare to the best, serving the citizen, and I think this is really half of the issue solved already. Thank you.
Unfortunately, we have to stop here due to the time constraint. And I would like to thank you all for your attention and active participation. And on behalf of you, I would like to thank our panelists for their valuable comments and talks. So please join me to thank them.
I'm doing this for Nick.
So thank you very much. That is, believe it or not, our closing panel to our 3-day forum, and it was a high note to end on and certainly an interesting one. What we'd like to do now is to give the awards, and we'd like to start with Dr. Al-Habani, please. Next, we'd like to honor Dr. Krishnan, please. Next, we'd like to honor Dr. Van ter Hayden, please. Next, we'd like to honor Dr. Swaylen, please. And we'd also like to honor Dr. Tawagri, please. So now we'd like to have everybody stay for lunch. We will be having opening luncheon remarks in just a bit with Steve Lutz, who is Executive Director from the U.S. Chamber of Commerce. And then he will be followed by our keynote speaker for the luncheon, Dr. John Duke Anthony, who is founding president and CEO of the National Council on U.S.-Arab Relations. I would like to give a special thanks to Mr. Adil Shakur of XS Conferences, who was very involved in putting this production together, the forum, and worked side by side. So, Mr. Shakur, thank you very much, and great that you were on board, and it was your support and your help that brought this to fruition. So, if you'd come up, please, for a minute so we can acknowledge all of your contribution and your help. And again, it was your vision and magic that gave us that splendid opening ceremony and brought the Prince here to bless our exhibits and our forum. Thank you.
Thank you. I want to thank everybody for their participating, for their contribution, our partner, Mr. Rancer Potter, and everybody, and hope to see you, inshallah, next year, 25th of April, the same place in Riyadh. Thank you again.
So now I'd like to ask Mr. Steve Lutz to come up, please. Again, he'll give some opening remarks before our keynote luncheon address. by Dr. John Duke Anthony. Thanks, Steve. And I would also like to mention that the Chamber of Commerce has been with us from the start. They had the vision and certainly gave us the support to grow as we have. And for that, I'm very grateful and blessed and really appreciate the Chamber's support. Thank you.
Well, thank you very much, Ransel. And I do want to begin by thanking you and C3 for the longstanding partnership with the U.S. Chamber. We have been working with you from the beginning. It's been a wonderful relationship. And I must say that while we've had a lot of fantastic conferences, I do believe this is the most successful one yet. As a big baseball fan, I'd say a home run or a grand slam. And of course, much of the credit for this success goes to our Saudi friends who deserve recognition for convening such a summit on such an important topic here in the kingdom. And it's really a tribute to His Royal Highness and the leadership here in Riyadh for having the vision and appreciation for the importance of the healthcare sector. And it truly is a critical sector. It's the one sector that has the attributes of being both transformative for a society and incredibly personal. Transformative in the sense that a modern, accessible healthcare system can improve the lives of literally every single citizen of a nation, and incredibly personal in the sense that it literally impacts the well-being, the quality of life, and the time that we spend here on this earth. So I truly want to thank the organizers for holding this conference and advancing the conversation about how we, as Americans and Saudis, can work for an even greater collaboration to boost investment, increase innovation, and enhance competitiveness of the healthcare system here in the kingdom to the benefit of all stakeholders, including the millions of citizens here in Saudi Arabia. And because they do represent business, the private sector, I want to convey that U.S. companies from the range of fields that have direct as well as indirect inputs into the healthcare system stand ready to deepen and expand our relationships and interest in the kingdom. And we most welcome the opportunity to engage Saudi officials in an important dialogue about those very conditions that boost investment, increase innovation, and enhance competitiveness. And there have been a multitude of ideas and insights raised and discussed over the past few days, but one in particular struck me yesterday during a panel on public-private partnerships, and it was raised by Dr. Sami. And Dr. Sami asserted, and I'm paraphrasing, that it's important for businesses and investors to have a strong sense of regulatory certainty. And we at the U.S. Chamber would certainly concur on that. For investment to grow and business to thrive and contribute to the healthcare system, it's imperative that the rules of the game are consistent and stable. And we do believe that here in the kingdom, there's a deep understanding for Saudis and appreciation for this as you aptly present the kingdom as a nation of a beacon of enduring stability and civil stability amidst an unrest sea of change here across the region. So there's a real and fundamental appreciation for stability and consistency, and having an outlook of stability and consistency applied to the regulatory framework sends a strong signal to investors and businesses alike. And when there does need to be change to adapt and modernize a regulation or law to reflect the new development, having consultation and input from industry is key. And the U.S. business community and the companies that are already invested here in the kingdom and those that will be in the future welcome and value this sort of important, constructive, and engaging dialogue and relationship with Saudi Arabia as we work in partnership to fulfill the important vision you've set forth for this critical sector. We believe the future of healthcare here in Saudi Arabia is bright and is only limited by our imagination, and we look forward to working with you to build an even more robust and dynamic and stronger relationship moving forward. And speaking of individuals who have an enduring and strong and long-standing relationship with the kingdom, I have the great honor of introducing Dr. John Duke Anthony, founding president and CEO of the National Council on U.S.-Arab Relations. Dr. Anthony, in addition to that capacity, also serves as the State Department's Advisory Committee on International Economic Policy. And for the past 39 years, he has been a consultant and regular lecturer on the Arabian Peninsula and the Gulf for the Departments of Defense and State. He is the former chair, Near East and North Africa program at the Foreign Service Institute at the Department of State, as well as the chair of the department's Advanced Arabian Peninsula Studies Seminar. And this is the United States' leading educational preparation program for select American diplomatic and defense personnel who are assigned here to the Arab world. He's a life member of the Council on Foreign Relations since 1986, in this capacity he's been a frequent participant in study groups on issues relating to the Arabian Peninsula and Gulf regions and the broader Arab and Islamic world. He's also served as an adjunct professor at the Georgetown University School of Foreign Services Center for Contemporary Arab Studies. And since 1986 and to this very present day, Dr. Anthony has accompanied more than 200 members of Congress and their key senior staff here on fact-finding missions to the Arab world. He's also the author of 3 books and editor of 4th and more than 175 essays and articles about America's interest and involvement in the Arab countries, the Middle East, and the Islamic world. Ladies and gentlemen, please join me in welcoming our luncheon keynote speaker, Dr. John Duke Anthony. Thank you.
And right before we bring Dr. Anthony on, I'd like to give Mr. Lutz an award, too, for his participation and support in making this happen. And now it's my great pleasure to ask Dr. Anthony to come up to the stage and give the keynote luncheon address, which will be the closing address for the U.S.-Saudi American Forum. Thank you.
Thank you, Ransel. Thank you, Mr. Lutz. And thank you for all of you who have remained till this last particular session. My remarks will be divided into 3 categories. One will be where we were and how we got to where we are. The second will be where we are in terms of pluses and minuses and challenges and opportunities. And then I'll try to close on where might we go forward from here. In terms of how we got to where we are, where we were, I made some brief references the first evening to this relationship going back far further than most are aware. Most references in the United States are to a meeting 70 years ago this year between America's then President Franklin Delano Roosevelt and the founder of modern-day Saudi Arabia, King Abdulaziz bin Abdurrahman Al Saud, on February the 14th, 1945. And yet the relationship predated that with regard to American medical personnel coming to the kingdom every 3 months, staying for 1 week, and treating patients and those in need without asking anything in return. And as early as the 1950s, working with Aramco, the effort to erase trachoma was a successful one. And we have Dr. Salwa Al-Hazar, one of not just the kingdoms, but the regions and the world's leading specialists in eye diseases, diagnosis, assessment, and treatment, who has graced our presence in this conference. And then in the 70s, with the working together with the establishment of the King Faisal Specialist Hospital, the 80s, King Khalid Eye Hospital, and carrying on from these chapters in medical diplomacy, straight through to recognizing that diseases do not require a visa. and the collaboration between our two peoples, working through the Center for Disease Control regarding avian flu, MERS, SARS, HIV, AIDS, and other challenges have benefited both of our peoples, the region, and the planet as a whole. During this process, at the same time, has been the educational component, which has not been confined to education and healthcare and medicine alone, but across the board, almost equally between the arts, humanities, and the social sciences on one hand, and the hard sciences and technology on the other. Ponder the following, that there are at least 200,000 Saudi Arabian graduates from American institutions of higher education. And except for a handful of Americans who've graduated from Al-Qura University in Mecca and the Islamic University in Medina, there are fewer than 20 Americans who've obtained their education here in Saudi Arabia. And what this says has immense implications for both partners. That is to say, there is a gross imbalance or asymmetry between understanding between hundreds of thousands of Saudi Arabians and very limited and sometimes false and unfair and inaccurate understanding by Americans of Saudi Arabians. This is not healthy for either side. But on the American side, the United States is the beneficiary of the English language, which is the lingua franca for research and development in science and technology, not just in the bilateral relationship, but worldwide. And this is something to which we have both put our shoulders to the wheel and derived enormous benefit from. Now, in terms of this cooperation and this strong foundation, which, by the way, was mutually beneficial from the beginning, reciprocally rewarding from the beginning, and it's been ongoing without stop, straight through the Cold War, where both of us were joined at the hip, so to speak. And just ponder that 8-year period of the Iran-Iraq War from 1980 to 1988. When working together, we both succeeded, with the help of Pakistan and others, in driving the last nail in the coffin of the Soviet Union and international Marxist, Leninist ideologies and communism. And simultaneously, we brought the Iran-Iraq War to an end. We put the American flag on Kuwait's tankers and safely escorted them into and out of the Gulf. And together we prevented the Iranian Revolution from expanding to the west side of the Gulf. A challenge then, as much as it is a challenge now, although the dynamics and the facets presently have changed significantly, though they're no less urgent, timely, and relevant to both of our respective national security and related threats. And during this time, ponder the following additional fact, that since 1975, there have been more American-trained PhDs in Saudi Arabia's Council of Ministers, its cabinet, than there have been and are PhDs of any kind in the United States cabinet, the Supreme Court, the Senate, and the House of Representatives combined. And racing through that is an element of trust and confidence that is hard to come by, and that has been the envy of virtually every other country on the planet. And yet, truth and honesty in speaking and analyzing requires that one acknowledge the following that has been less than healthy. That is to say, on September the 11th, 2001, this was a watershed in the relationship for many Americans. But many Americans are not aware that March 2003 was a watershed for many Saudi Arabians from the same challenges to their national security and related interest. But on the American side, the unhealthy aspect came in the form of the so-called Patriot Act, which, if read closely, is inescapably focused on Arabs and Muslims. In terms of Americans from then and to an unhealthy degree to the present, too often seeing Saudi Arabia as a gas station, not a country. Too often seeing Saudi Arabians and the country as an object to be controlled, influenced, coerced, cajoled, manipulated at whatever cost, as opposed to seeing the kingdom also as an actor with its own legitimate needs, its own legitimate rights, its own legitimate concerns, its own legitimate aspirations and objectives and goals. And still too many seeing Saudi Arabia as a mountain of money, rather than as the heir to an extraordinarily rich culture and civilization that has benefited not just the two respective peoples, but all peoples globally, worldwide. This aspect has been dealt with effectively in some cases, but leaving a lot to be desired in others. For example, no two countries have been and are to this day cooperating more closely and effectively and respectively in counterterrorism than our two countries. As I speak, Saudi Arabians and Americans in Riyadh and elsewhere are side by side exchanging information, analysis, intelligence, and insight related to the national security of both peoples in the broader region and global well-being at the same time. And throughout this period, in addition to cooperating on these issues, Saudi Arabia has remained wedded to the dollar as the instrument of exchange in its financial transactions with one and all. And this has benefited the United States immensely in the standard of living and the material well-being of both countries beyond what is ordinarily known, accepted, or understood and respected. As recently as 5 years ago, actually 7 years ago, with the international mortgage, housing, financial liquidity crisis, it was Saudi Arabia that insisted it would no longer play the role it had played mainly in the past of being with America on the crash landing, but from that point on, it insisted it would be with the United States on the takeoff as well. This is the origin of the G20 with regard to Saudi Arabia's pivotal role in the center and its influence not only on behalf of Saudi Arabians, but those in the Gulf Cooperation Council, the League of Arab States, and the broader Organization of the Islamic Conference of 1.6 billion Muslims. In terms of challenges at the present time, they're twofold in the sense of a joint awareness that a healthy people is essential for healthy economies. And healthy economies are essential for healthy social stability. And healthy social stability and economic stability is essential for national security and national stability. And these four are essential for the prospects and potential for prosperity. And so both of us have no daylight between us in that assessment. Each of us is aware also of the healthcare demands of our respective peoples. And here's where we're similar but different. We're both vast in our territory, but you are in many ways a continent more than a country. You have 13 neighbors. The United States is blessed with having 2 oceans among its neighbors and friendly neighbors such as Canada and Mexico. Would that many countries were that blessed. And yet, where both of us are commanded to provide health care services for all of our people, your approach is different. Yours provides health care services without regard to race, creed, or religion. In the United States, it's legal that way, but there's no denying that there's still racial inequalities and economic inequalities that have eluded the best efforts at resolution and solution. Americans can learn much from Saudi Arabians in this regard. And Americans can learn much from Saudi Arabians in additional ways as well, in terms of Saudi Arabia's emphasis on the family, and especially children, and the elderly, and charitable giving, and compassion, and justice. And Americans too often forget the emphasis on justice, even though in the Pledge of Allegiance to America's flag, the phrase of liberty and justice for all is as relevant and timely and urgent now as it has ever been since that phrase was coined. There is the aspect that Americans can also learn from Saudi Arabians in terms of the following: that you, far more so than we, if at all ourselves, are close to the cradle of Western culture as Western culture is known. You're part of the crucible of Western and worldwide civilization as Western and worldwide civilization is known. You are near the intersection of three continents, Africa, Asia, and the Middle East. You are close to the anvil of antiquity. You are nearer than we are to the source of sunshine on the classical world. And you are at the epicenter of prayer and pilgrimage, of faith and spiritual devotion for the 1.6 billion Muslims, nearly a quarter of humanity. All of these things we can learn from you. And fortunately, the atmosphere from this conference and before and everything leading up to it has been more receptive than in quite some time. And the moment for our cooperation is as propitious now as it has ever been. And we can take solace and comfort in our joint awareness of the need for collaborative research on communicable diseases and sharing knowledge and understanding and information on communicable diseases and the entrance and the exit challenges of our respective peoples. Some 70,000 people come into the United States every day from other countries. And here in Saudi Arabia, you have 2.1 million pilgrims that come from all of the Islamic countries throughout the planet. No two other countries have challenges remotely commensurate to these in terms of an objective common interest, a common need, a common concern, a common aspiration and objective. And both of us are aware of the rising demands for health care of a quality and quantitative extent in both of our countries and societies. And we're equally also aware of the rising cost of health care and the need to find innovative, creative ways to keep those costs in check while not compromising the quality of the health care. And we both share a oneness in the humanity and the humaneness and the usness of health care. A person who's trying to have something taken out of them or treated effectively with medicine does not care, and rightly does not care, where the doctor or the nurse comes from. Human pain and sickness and illness is the same without regard to religion, without regard to ethnicity, without regard to nationality. In this, we are all one as well. On the educational side, you have 110,000 Saudi Arabian citizens in the United States and institutions of higher education at this time, with a high emphasis and value on medicine, nursing, and pharmaceuticals. And the need is to build on the 30-some thousand Americans who are here to bring more Americans into collaborative research and joint authorship, joint lab work, joint technicians, joint creativity and innovation in the realm of medicine and healthcare. And each of us realizes, not too late, that it is far more economically effective to treat diseases before they begin in terms of preventative medical care rather than managing or administering diseases such as cancer and cardiovascular and diabetes and obesity, which afflict both of our peoples to an embarrassingly horrendous extent. And something else that is new between our two countries in the field of healthcare and medical cooperation is in the realm of internships. This has been a long time in coming, but I urge, as do others urge the Saudi Arabians amongst us, to urge their American counterparts to try to find ways before these Saudi Arabians return to the kingdom to have had practical, effective, hands-on experience and to bring that back to the kingdom to share with others. And this one-on-one working together in a collaborative venture is bound to produce results of benefit and reward to not just both of our peoples, but the region and the world as a whole. Indeed, Saudi Arabia, being the headquarters of the Gulf Cooperation Council Secretariat, can serve to an even greater degree than it has as the example, the model for breakthroughs here that can be shared with Kuwait and Bahrain and Qatar and the Emirates and Oman, as well as when peace is restored to Yemen, to the people of Yemen as well. Here we have a situation that needs to be italicized, neonized, and capitalized, of bringing this training and education front and center to build on what we have and what we have going for ourselves, to keep this chapter in medical diplomacy going forward, and to go from strength to strength in our achievements and accomplishments in regional affairs that bear directly on security and stability and war and peace. Both of us are acknowledged leaders. Neither has to apologize to anyone for the blessings and the role and the resources and the assets that have been bestowed on both of our peoples and our leaders and governments. And it is heartwarming, to be sure, to learn in the last few hours that the new Minister of Health, Khalid Al-Thali, Chief Executive Officer of the world's largest petroleum company, will now bring the administrative gifts and accomplishments and achievements for which Aramco is renowned to the Ministry of Health, which requires a strong administrative hand and strong personalities behind those administrative gifts. Indeed, Saudi Aramco is renowned for tackling large projects, which national healthcare systems are indeed as large national projects, and to completing them on time and within, if not under budget. And these are commanding principles and values and ideals enshrined in the mission and the mandate of Saudi Arabia's Ministry of Health, as within every country's Ministry of Health. We are, in short, leaders at the global level and at the regional level, and together each empowers the other to be more effective than were we to be alone. Again, returning to the oneness of our humanity, especially as it is manifested in the field of medicine and healthcare services, facilities, buildings, cost, and quality. In short, despite the obstacles that we continue to confront and not run away from, both of us have a record for which there's no need for an apology. I know of no two countries anywhere in the world that, despite our difficulties, would not trade places with the two of us within a matter of seconds. It is clear that on both sides, none of us are bereft of blemish. None is devoid of defect or free from flaw. And clearly we are on a sea from which we can see, but we have not yet reached the farther shore. But together we know we can, though not by accident and not by coincidence. Only if enough good people on both sides work together day in and day out in the collaborative way that this conference has underscored, and to have more of these conferences, and to strengthen and expand the results from each one, and to admit our mistakes, and not throw money after failed ideas and projects and programs and events and activities. Own up to the mistakes, learn from our mistakes, share the knowledge and understanding that comes from such learning. All will be the better as a result, and we will reach that further shore to the betterment of both of our peoples and those in this region and the larger world. Thank you.
So, Dr. Anthony, I'd like to thank you personally again for everything that you've done. You are certainly an inspiration to anybody who wants to enter into this region, understand it, and be sympathetic with what is necessary to continue to move us forward together in a progressive and a very productive way. So for that, I'd like to thank you for your years of dedication, for your brilliance, and for your passion for making our communication with each other improved and binding as we go through these very tenuous times at points, but come out on top because of people like you. Thank you, Dr. Anthony. Now, before we conclude for the end of what's been a marvelous 3 days, we have one very special speaker that we've been waiting to hear from. She's blessed us by being here. She's inspired us by being here. And for that reason, I'd love you all to hear from her personally. Dr. Salwa, will you please come and take the stage?
Bismillah ar-Rahman ar-Rahim, wassalatu wassalam ala Sayyid al-Mursaleen. What an honor to be able to do the closing remarks for the C3 Saudi American Healthcare Forum 2015. I was only told about this about an hour ago. So if you see me holding the paper, it's just trying to get all the sessions and everything under one umbrella. This forum has been held for the last 3 days in this location. I stand here as a Saudi who has attended many, many forums, and it is mind-boggling to see the governor of Riyadh, His Royal Highness, Prince Bandar al-Faisal, the Minister of Health, the King Faisal Specialist Hospital and Research Center, the Saudi Health Council, the U.S. Embassy, the National Council on U.S.-Arab Relations, Dr. John Duke Anthony, and the Shura Council, all participating in this forum to be able to bring all these people together under one umbrella. I consider this a major effort on the part of this forum. The first day, we had 6 interactive sessions, from personalized medicine to infrastructure to the emergency care. It was very interactive, and I know many of the people that actually attended this session had come out with a lot. And then yesterday, we had 6 sessions dealing with the outbreaks, the vaccine. And what a treat. It wasn't just the vaccine, but for the C3 to be able to talk about the halal vaccine, which to me was something I had never heard about. That again tells you that this forum was tailored to the Kingdom of Saudi Arabia, to the Arab countries, and to the religion Islam. It talked about governance, about sustainability, non-communicable diseases. They talked about diabetes, and we know not only is it a global problem, but also a major problem here in the Kingdom of Saudi Arabia. Yesterday they talked about partnership, so it tells you a lot. Today, in the 6 sessions they had, they talked about knowledge transfer between the Kingdom of Saudi Arabia and the US. And we were honored with the KFSH staff who actually ran the whole session. They talked about patient safety. They talked about the primary health care. And a forum of this magnitude, knowing that these 2 major issues, patient safety and the primary health care, are major burdens to the Kingdom of Saudi Arabia, and to be able to bring experts, not only from the Kingdom of Saudi Arabia, but also from around the world to discuss this, this was a can opener, and this was a treat to those that had attended it. They talked about the health informatics and brought people, not only from the Kingdom of Saudi Arabia, but from different parts of the world, and telling us the importance. And what a treat when someone from another part of Saudi Arabia, from another part of the world says, is this really happening in Saudi Arabia? Do you really have this? And then last but not least, they talked about knowledge transfer. So what is so unique about C3? Have each and every one of you asked yourself what the C3 stands for? And I'm going to read it. It stands for community. It stands for collaboration. And it stands for commerce. What did this C3 forum bring? It actually, talking to the different people and networking, it forged new business relationships. It fostered existing partnerships. And there was exchange of the best practices through bilateral cooperation. The forum gave each and every one of us access to the best healthcare services in Saudi Arabia. It was learning about the resources and research that exist in Saudi Arabia. And it was not only for people from outside the kingdom, it was also people in the kingdom, knowing that that specific institute did this and this specific institute did that, and to be able to collaborate. So it was not just a learning resource for people from outside, it was actually a learning resource for the people in the Kingdom of Saudi Arabia. Why do we all do this? Why, when it comes to something in the health forum, why do you see so many people attending, so many people participating? If you look at the different departments or different health or different sectors, you can live and die and never go into a certain ministry. You can live and die and never know about a certain department. But when it comes to health, from the day you are born till the day you die, health is part of your life, whether it's for you, whether it's for your family, whether it's for your friends. Health is part of our daily life. That's why in a forum like this, you see people are eager to learn and they are hungry for knowledge, because health is part of us. It's what we breathe, it's what we sleep on, and what we wake up on. Why are we doing this? We are doing this to improve the survival and quality of life. Who does not want to improve their quality of life? It's a fight, and I'm sorry to have to say that, but it is. It's a fight for a better and healthier life for ourselves, for our children, and most important, for our children who live in this interconnected world. So, Ransel Potter, Mr. Adil Abdul Shakur, I don't know how you put this wonderful forum under one umbrella, bringing everyone from every sector. Not only is it the health sector, but in order to be able to succeed in the health sector, you need the other sectors involved. To be able to do this in such a short time, I commend you. Again, this is the first, but I promise you, with everything that has happened, it will not be the last. We are looking forward to next year, as rightly Mr. Adil mentioned, and also in New York on June 15th, if I'm not mistaken, there is another forum. So once again, I congratulate the organizing committee, and we do not want to forget those young girls and boys behind the scenes who have been the right hand of Ransel doing everything. I would like to give them an applaud. From morning till night, they have been a part of this forum, making it successful, ensuring that each and every one of us got personalized care. So it's not only personalized medicine, it was also personalized care. Thank you all very much. We thank all the organizing committee and people who has made this a reality. Thank you.
Thank you, Dr. Salwa, and thank you everybody for listening, and her inspiration gives us encouragement to keep moving forward. And I'd like to announce too that we've been contacted, and King Faisal, along with the Saudi Health Council, have given us their support to continue forward with the next forums, and we're delighted for that. So with your blessing and your guidance, Dr. Salwa, we're sure to have a bigger success next year. Thank you.
Thank you.
And now,
Thank you.
now we have to give you your award.